Hello, good morning. Welcome you all for this new session of ONG emergencies and under obstetrics and gynecology VIVA sessions. Okay, so first of all, I would like to welcome you guys for this new session. Okay, so I think some of you may be knowing who I am, but some of you all may not be. So let me just give a brief introduction about myself. Okay, so my name is Wasantha, as you all know. Okay, so I was involved with the ERPM teaching for years, actually, over last years. However, last year I was not in the country because I went for my foreign training. So I couldn't conduct any classes over the last 1 year. So I'm back now. So hopefully I'm going to start this new series of classes. Okay, so those days I was used to do these live classes. Okay, but now the trend is different, technology is different. So first of all, you have to apologize me because I'm doing this, still I'm under quarantine. Okay, so I'm in a hotel, so I'm doing this session through my mobile. So at the moment, I don't have any hi-fi gadgets with me. Okay, but hopefully within few days time, um, I'll be able to arrange everything, a good setup. Okay, so if there's any problem with the quality of the video or anything, just apologize. All right. So next time it's going to be a good video than this. Okay, however, I'm trying to do my best, and uh, with this gadget also I'm going to do the best, and so we can continue. Okay, so another thing is I have to say thanks to all the teachers who involved with the teaching for you guys, because they made some contribution. That's why you all got through, and you are here today after completion of your theory part. Okay, so my role is I will take you guys from here, and I will show you, I will direct you to the success, the rest of your journey. Okay, so that will be guaranteed. Okay, so we'll start. So if you want to ask any questions, this is a live session. Okay, so and should be interactive session. Okay, so if you want to ask any questions or anything, you are welcome. You can put a you write down, and you can send a chat. Okay, so I'll go through it leisurely, and during the interval period also I can go through it. Okay, so or else you can even send a message to my WhatsApp messenger or anything, so that we can discuss in detail. All right. So now this class is mainly, I'm targeting mainly the Viva students, because they have the exam in upcoming months. So I'm targeting them. However, this will be beneficial to the theory students as well. Okay, theory students, you may not be having the basic theory knowledge with regard to the emergencies. Okay, that is nothing to be worried. Okay, I will guarantee I will do a separate class, theory class for you guys. Okay, and that the theory I will cover A to Z everything. Okay, so some of the stuff that I'm going to discuss today may not be fully convinced to you guys, for the theory students I'm talking. Okay, but don't worry. Okay, just listen. Okay, then when we start the theory classes that I'm going to start soon. Okay, so then it will not be a problem. But the Viva students, since they have already completed their theory part, most likely they will not have any problem. So what I'm going to do is, initially I will give a brief basic theory part, which is necessary for the Viva. Okay, so I'm not going to go into the details from A to Z regarding the theory. Okay, because practically it's not possible in this class. Okay, but I will point out the important facts in the theory, That is important when it comes to the Viva. Okay. All right. Then now, other thing is, now this is mainly a Viva class. So what is the difference as far as the exam is concerned? What is the difference between the Viva and the theory? Okay. One of the difference is the theory. When it comes to the theory, the syllabus is very big. Okay. So it's a very huge syllabus. Okay. So you are supposed to know each and every minor single points. Say, for example, they might ask you about the mitochondrial problem sometimes. They might ask about the tiny things also can be questioned. But so in that way, theory, you have more things you need to study. Okay, because the syllabus is big. But when it comes to the Viva, it's totally different. Viva means now you have already completed your theory part. Okay, so in the Viva exam, they are not expecting from you guys very minute, tiny pieces and pieces. Okay, so they mainly assess few things in the Viva exam. That's how it different from your theory. Okay, one of the main key thing in the Viva exam is, okay, or the clinical exam is, they will assess your confidence in the exam. What do I mean by the confidence? Confidence is the way you tackle the patient, because you are dealing with a live patient, okay, in Vivas, okay, not in the emergency, but the Viva as a whole, right? So you will be given you will be given two cases, that is one obs patient and one gynae patient. Okay, there are no short cases, ultra short cases, micro cases, or anything. Okay, it's only two long cases, because as gynecologists and obstetricians, we are pretty straightforward. Okay, so we don't have these minor cases. Okay, that's a good thing. So you are given two patients. Okay, one is an obs patient, one is a gynae patient. That's all. Okay, and a separate emergency viva like today. Okay, so the confidence is how you are going to talk to the patient, how you are going to develop the rapport with the patient. That is very important. They will assess that thing, because when you are taking the history, one of the examiner will observe you, how you talk to the patient, how you respect the patient's dignity and all. Okay, so that is very important. Okay, so they will assess. That is one confident thing that will assess under confidence. Other thing is, when you are after taking the history, how you are going to present your case. That is very important. Okay, so when it comes to this point, okay, most important thing is, if you are a confident person, you should be able to maintain a good eye contact with the examiner. On the other hand, if you're not confident with your knowledge or with your case or the overall, okay, then you will be like this. Either you will be counting the number of stars that you can see, or either you will be counting the number of sands on the floor. Okay, but if you're very confident, you will have a very good eye contact with the examiner. Say, for example, a nice pretty girl comes and examiner is a male examiner. Okay, a nice pretty girl comes and presenting with having a very good eye contact with the examiner will be embarrassed, and he will be, I mean, no way, so he will not pick up even minor mistakes that you are going to do. Okay, so he will be so impressed. Okay, same way. Okay, even a boy, don't worry, boys. Okay, you have also a chance, because there are some female gynecologists also. So if you maintain a good eye contact with the examiner, okay, even you made a mistake, silly mistake, sometimes they will not pick up those things. They will think, oh my God, this is awesome, and this guy is awesome, and he's so confident in the field. Okay, so that is number one, very important. You have to maintain the eye contact. Hello, any problem with the video? Good. Okay, right. So I'm talking about the confidence. Okay, so when it comes to confidence. Okay, so thanks. So, when it comes to confidence, okay, so very important in the exam, okay, you have to maintain eye contact with the examiner. Even you don't know anything, just look at the eyes of the examiner. Okay, examiner may be having a very staring, very scaring the appearance, but don't worry. Okay, you smile. Okay, modek pagi hinamin na ni. But in a professional way, you smile and have a good eye contact. Okay, that is what is called confidence. Believe me, in my final MBBS exam, okay, a long time ago, okay, in my medicine, we got like you guys, we got four the minor cases, okay, the system examination, and in all these examination in the cases, my diagnosis were wrong, but I got a very good rank in the final MBBS. I was within the first 20, okay, because of my confidence of presenting. So that ability you need to build up. Okay, so I will be more concentrating on this aspect, and I will give you more facts how to build up your confidence throughout this process, because most of you guys by now you are having the knowledge. What matters is the way you present this knowledge in the exam. Okay, that is for that matter you need to have this confidence. The other thing is another. There are three things they're going to assess in the exam, viva exam. One thing is the confidence. Next thing is your ethical aspect. Okay, that is uttermost important. Okay, what do I mean by the ethical aspect? One of the thing is how you, as I mentioned to you earlier also, how you tackle with the patient, how you talk to the patient. Okay, and how you communicate with the patient, how you respect the dignity of the patient. What do I mean by the dignity? So you don't examine a patient, you don't examine, these are all, we are dealing with females, they are so sensitive. Okay, compared to males. Males, we don't mind, even somebody comes and pull your serum down, we don't mind. But when it comes to females, they're so sensitive about these aspects. So we are talking about extremely personal things like the menstrual history, like the sexual history and all. Okay, so you should be a very professional person. Professionalism is very important. And the other thing is, you don't expose a patient in front of a big crowd. You don't do abdominal examination or a vaginal examination in front of thousands of students or thousands of audience. Okay, that is what is called the ethics. Okay, you have to maintain that ethics in the exam also. If there is, most likely in the exam you will be given a male examiner and a female examiner. So in that case, you don't have to ask for a chaperone. But if there are only two male examiners, you have to ask for a female chaperone before you do the examination. Okay, please remember those things. This ethical aspect is very, very important. Sometimes you may be very confident person, very knowledgeable person, but still, if this ethic part is not there, if you don't respect the patient's dignity, if you just expose the patient, if you just talk about the patient matters in front of a crowd, if you're just doing some bloody things, okay, then of course you are going to fail the exam. Okay, that is very, very, very important. Okay, third thing is do no harm. That is the third thing they are expecting in the viva exam. So the first thing is you're confident. Second thing is the second thing is your ethical aspect. Third thing is do no harm. What do I mean by do no harm? So in the exam, okay, you can do mistakes. I mean, we all are students. We are not experts. You all are not consultants. Okay, you can do mistakes. That's acceptable. However, your mistake should not kill the patient. Okay, that is very, very important. Say for example, patient having the eclamptic fit, the examiner will ask, okay, what is your drug of choice? If you just say, I will consider giving methyl dopa or diazepam, no, that is not the answer. Answer is because by giving that thing, delay the treatment of the patient and patient can die. That's a real emergency. So what's the drug of choice? It's magnesium sulfate. Okay, so you have to give that answer. You don't tell the other things. So you have to give the answer. Okay, so that is what is mean by do no harm. Okay, so you have to do especially in emergency situation, you have to do the best thing for the patient. Okay, you can't take a risk. Okay, so guys, if you want to pass the Viva exam, it's very easy. The syllabus is not that big. Okay, and uh, syllabus is not that big. Other thing is, it's very easy to pass the exam compared to uh, this the theory exam. Okay, so please try to concentrate on these three things. Just give me 1 second. Okay, so okay, so when it comes to the emergencies, the Vivas is very important. You have to maintain your confidence. Then the second thing is you have to respect and you have to maintain the ethical things. Okay. Third thing is do no harm. So if you do all these three things, okay, then definitely you will pass the exam. You don't need to have a knowledge from A to Z. Okay, clear? Right. So that is how it differs from the theory from Viva. And the other thing, of course, in theory, you can go to the exam, okay, you can write down or you can mark anything and you can come back home and tell that do nanikang etti helenda, like that, okay, because nobody knows what you have written till you get the exam. You have 2 3 months to come, so you can celebrate. But in Vivas, of course, you know what you have done. So the results will be more immediate because the examiner is watching you. Okay, so they will decide then and whether you are suitable, whether you are a suitable person for a to become a house officer. Okay, or whether you are not suitable. They will not assess your surgical skills, like whether you can do a hysterectomy, whether you can do a overtime hysterectomy, or whether you can do a cesarean section, whether you can do a the ERPC or anything. They will not assess those things. Okay, they will assess basic things that I'm going to explain you in the latter part of this journey. What are the procedures that are expected from you guys in the exam? Okay, all right. Okay, so all right, then after having all these things, okay, so we will be moving to our topic, that is obstetric emergencies. Okay, all right. Okay, so if there's any problem while I'm conducting this class, because this system is quite new to me, okay, so I may not be perfect with the technical aspects. So if there's any problem, please give me a feedback so then next time I can correct that thing and we can proceed. Okay, right, good. Then when it comes to obstetric emergencies, the obstetrics is, you can't discuss about obstetric without discussing emergency. It's like bread and butter. Okay, so obstetric emergencies are so common in day-to-day practice. We will encounter these problems. Okay, so it's, again, it's not like, you know, your theory paper. When it comes to theory paper, you got, you know, all the four the responses look same. You don't know what to choose. Okay, but in come to the emergencies, there are nothing like that. It's pretty straightforward. They will give you a scenario, okay, and then ask what you are going to do. That's all. You don't have to select, okay, which one is better than the other one, what is the most suitable one, like that. There are no, like, nothing like that. Okay, depending on the clinical scenario, you have to find the answer. And the other thing is that when you are preparing for the exam, okay, don't wait till the last moment to do your things, because most of the people, they think that, okay, obs and gyne, oh, obs and gyne is nothing, you know, it's just everything can be covered with a small panty, you know. All right, some people have idea like that. Oh, when you come to medicine, oh my God, you have to study from top to bottom. But obs and gyne is nothing. No, not because I'm teaching obs and gyne, okay? It's very important for you guys to pay the similar attention on this subject as well. Otherwise, you are going to, at the end, if you try to study everything, it's going to be a mess, okay? And don't wait till your the best friend start studying. then you can study. No, you have to start from beginning. Otherwise, you will have to, like, the monkeys, you have to see the other people. Oh, that person is going to class. My God, he's studying and studying and studying like that. So no, okay. So you all have to start. If you haven't started now, you need to start today itself. You have to target your exam. Always study exam oriented way, because ultimately your target is to pass this hurdle. Okay. Sorry about these background noises. All right. Okay. Under obstetric emergencies, the first thing I'm going to discuss is what is called maternal collapse. Okay. All right. So what do you mean by maternal collapse? What's the definition of maternal collapse? The definition of maternal collapse is acute event. It's an acute. It is not like chronic asthma. Patient is dying because of chronic asthma. Patient is dying because of corona. No. Okay. Maternal collapse is defined as acute event involving either heart or the lung or your brain, leading to or resulting in either reduced or absent conscious levels or a potential death, which can happen throughout your pregnancy period or up to 6 weeks after the delivery. That's called the postpartum period. Okay. So from the time of conception, suppose now all of a sudden there is a news coming. Okay. Today the online class is cancelled. So everybody is, they have told the parents that, okay, you have these meetings and all, but ultimately the exam, this class is cancelled. So what happens? The girls and boys, they go here and there and they have leisure time. Suppose they conceive today, somebody conceives today because of this leisure time. Say, for example, if somebody conceives from that point up to the full term delivery or up to 6 weeks postpartum period, if something happened with the heart, lung, or the brain leading to reduced conscious level, that is called acute event, that is called maternal collapse. Okay, all right. So you can see when there's a demonstration, okay, when there's a maternal collapse, it's a real emergency because the brain can go hypoxic. If the brain hypoxia persists, either patient is going to have a brain death or totally patient will be septopochi. Okay, so it's very important to identify this condition and manage the condition, maternal collapse. Okay, so then what are the causes for a maternal collapse? If you just leave the maternity, if you take another, the non-pregnant patient, what are the causes? A patient can suddenly collapse. There is an easy way to remember this. There are 4 H's and 4 T's. What are these H's? What are these T's? Hypoxia. One of the H is hypoxia. Okay. So if a patient get exposed to hypoxic condition suddenly, okay, the consciousness will totally go down and patient can even die. So hypoxia is a known cause. Hypovolemia. This is very important in obs and gynae because hypovolemia means, hypovolemia means, now say we are going to discuss later part of this discussion is about the hemorrhages, bleeding. When the patient is having massive hemorrhages, okay, especially postpartum hemorrhage, patient can bleed a whole lot of blood or the total volume of blood within a couple of seconds. It's very dangerous. So acutely patient will be hypovolemic and that can lead to collapse. So one of the commonest and most common reason for maternal collapse. Okay. So the other thing is hypoxia, hypovolemia, potassium problems. Either potassium is low or potassium is high. That is called hypo or hyperkalemia. Right? With metabolic disturbances, these things can happen, especially patients with preeclampsia. So that can lead to maternal collapse. Other thing is not very common in our country, but hyperthermia or hypothermia. Okay, this is not commonly seen in our country, but in other countries, it's a common cause of maternal collapse. Okay, both either hypo or hyper. Those are the 4 H's: hypoxia, hypovolemia, hypo or hyperkalemia, and hypothermia. When it comes to the T's, thrombosis. This is very important again, especially, okay, Thrombosis means, you know about the thrombosis during pregnancy, almost all the women are having a higher risk of thrombosis. Okay, if there's a blood clot, they can ascend and they can go into the heart, and they can go into the eye through the IVC, they can go into the heart, and through the heart they can go to the lungs and they can block the lungs completely. This is called pulmonary embolism. Okay, it's not a common problem in our country, Sri Lanka, but when you go to countries like North America or even United Kingdom, okay, this problem is a massive problem for them, but not for us. It's not very common in Sri Lanka. Other things are like the tension pneumothorax. If there's a bully and if it ruptured, okay, that can cause tension pneumothorax, and that can cause this problem. And the cardiac tamponade. If there is a cardiac damage, that can cause tamponade and cause this. Other things are like toxins. Okay, toxins also is a known factor for, you can understand if there's any toxin. If you take any strong toxin like cyanide or something, you can suddenly die. Okay, so these are the 4 H's and 4 T's for maternal collapse. In addition to these are the common things for each and every person, adult, for you and me. Okay, suppose we are not pregnant. When it comes to pregnancy, other causes also, there are specific other causes. One of the other cause is eclampsia. Okay, patient can develop eclamptic fit, and patient can either die or patient's consciousness can go down. Okay, it's a well-known cause for maternal collapse. Okay, eclampsia. Remember, in addition to this list, other thing is amniotic fluid embolism. You would have heard sometimes. Sorry about these background noises. Okay. Other thing is, within the uterus, there is amniotic fluid. Okay. When this amniotic fluid leak into the maternal circulation, this can be very, very toxic. Patient can suddenly die. This is called amniotic fluid embolism. So in addition to these 4 H's and 4 T's, remember what to remember: amniotic fluid embolism and thrombosis. Okay. So how are you going to manage any of the patient who is having a collapse or unconscious? We have 3 or 4 or 5 basic steps to approach. First thing is airway. Okay, because if the airway is obstructed, whatever you do will not be effective. So first thing is secure the airway. What are the ways you can secure the airway? Okay, if there are secretions or any foreign bodies outside the oral cavity or within the mouth, or not deep but outside, okay, you can wipe them. Okay, clean the area, airway. Okay, and you can turn the patient into lateral position, ideal left lateral position, if you can do. Other thing is, Tarun, you can do another thing that is called a triple maneuver. That is head tilt, chin lift, and jaw thrust. In medicine, and they will discuss these things in detail. So by doing these 3 things, okay, you can secure the airway. Okay, head tilt, chin lift, and jaw thrust. Okay, so to secure the airway, first thing is turn the patient into lateral position. If there is any secretions, just clean the secretion. And you have to apologize me, okay, the medical people, they came just to check the temperature. So just me 1 second, I'll be come back. Okay, sorry. Sorry for the disturbance, okay, because they keep coming 2 times per day to check the temperature to see whether we are still infective or having the disease. Okay, I'm sorry for that. All right. So when there's a maternal collapse, suppose when you are in the ward, if a mother suddenly collapses, or when you are walking along the road, okay, a pregnant lady suddenly collapse, what will you do? The first thing is you have to maintain the airway, secure the airway. How are you going to secure the airway is you turn the patient in lateral position. If there are any secretions, you remove them. Okay. And if you're a confident person, you can do what is called triple maneuver. That is head tilt, chin lift, and jaw thrust. Okay, those are the things. By doing those three things, right, you can secure the airway till the support comes. Okay. Then next thing is the breathing. This is how the triple maneuver is going to turn, right? You have to do the head tilt and then the chin lift and the jaw thrust. Okay. Right. Then now you have secured the airway. The patient suddenly collapsed. We don't know the reason why this patient collapsed. So what you have, we don't worry. I mean, when a patient suddenly collapses in this kind of emergency, you don't go behind, oh, what is the reason for this collapse? Something happened, husband gahalada. Like that, you don't go behind the real cause for this collapse first. You have to do these three things: airway, breathing, circulation. Okay, airway. That's how you maintain the airway. Then the next thing is breathing. Patient is not breathing. What will you do? Okay. So if you are in the hospital setup, you can give oxygen for face masks. Okay. So give oxygen. Okay. Suppose you are not in the hospital setup, say a young pretty lady collapse on the floor. She is not breathing. You have maintained the airway. However, she's not breathing. A nice pretty girl on the floor. What will you do? So you have to give some oxygen. Okay. How you can give oxygen? You have to give oxygen by mouth to mouth breathing. But this is to some extent, okay. I mean, if you can do it, that will be great, but nobody can blame you by not doing it because we don't know what kind of diseases this patient is having. This patient may be HIV positive. Okay. So in that case, there's a reason for you to say, okay, that's why I didn't do it. But if you can do it, you have to do it. So if you're in the hospital setup, no worries, you can straight away give oxygen. Okay, so airway, breathing. Then the next thing is the circulation. So circulation, what you have to do is quickly check the pulse of the patient. Okay, sometimes in case of a collapse, you will not feel the peripheral pulses like the radial pulse. So what you have to do, check the carotid pulse. Okay, very important. Check the pulse. If the pulse is not there, okay, you have to start what is called cardiopulmonary resuscitation, CPR. You have to give the chest compression, and then meantime you have to give breathing as well. Okay, it's 30 to 2. When you give 30 compressions, okay, and then you have to give 2 breaths. So in the exam, they will not ask from you guys the details about CPR. Okay, but better to know because these things we know from the beginning, from the Montessori level, that how to do the PCR. Sorry, not PCR, so CPR. PCR for corona. Okay, CPR, cardiopulmonary resuscitation. So first thing, secure the airway, facilitate the breathing, and start CPR. Okay, so then you have to, while you are doing these things, okay, you have to call for help. It's very important because in case of this kind of emergency, you can't manage alone. Okay, you have to call for help. You have to call the ward people or the surrounding people. If this is happened not in the hospital setup, you have to call anyone. Please come and help me to manage this patient. Okay, so that is called call for help. Very important. You have to get the assistance from somebody and transfer the patient soon as possible to the hospital setup. When you are managing a patient who is pregnant and collapse, there's a thing called supine hypotension that you have to be aware. Okay, what is this supine hypotension? In this picture, in this slide, you can see when a patient, on your left hand side picture, okay, when a patient is pregnant and lying supine, okay, the baby or the fetus and the placenta and all these structures, gravid uterus, will directly press the aorta and the inferior vena cava against the spine. So when the IVC is compressed, the blood supply or the backflow to the heart will be less. When the venous return is less, the blood pressure tend to drops. This is called supine hypertension. That's why it's vital for you to turn the patient into a lateral position, especially when they are pregnant. When you turn them into lateral position, this pressure on these big veins and the arteries will be relieved so that the venous return will be improved, and that will facilitate your resuscitation part. So this is called supine hypertension. Because of this thing, pregnant ladies or the pregnant moms are allowed to sleep on the supine position, are not allowed, sorry, pregnant ladies are not allowed to sleep on the supine position after 20 weeks of pregnancy. After 20 weeks, because the baby is small, fetus is small, so this effect is not that strong. However, after 20 weeks, it's very important. All pregnant women, they should sleep into a lateral position. So they should be in the lateral position when they are on a bed, except for few minutes. For exceptional things, right? Few minutes is allowed, but few minutes are allowed. Few minutes will be enough, okay? But otherwise, pregnant mothers after 20 weeks, they should lie lateral to prevent the supine hypertension. Especially if you are managing a patient who is having maternal collapse, okay, you have to manage them in a lateral position to avoid the supine hypertension. Okay, now suppose a patient suddenly collapse, you don't know the reason still, okay? Now you are doing the airway, breathing and circulation, okay? You have secured them and you are now giving this cardiopulmonary resuscitation. However, patient is not recovering. You are doing the procedure continuously. However, patient is not recovering. So pregnant patients, they can suddenly, very acutely become hypoxic and brain dead if there is the collapse. So once you started your resuscitation, okay, that's the airway, breathing and circulation and the CPR, you continue the CPR process. If there is no response, you have to deliver this baby within 4 minutes. That means, now suppose you start the CPR process, okay, 4 minutes gone, but the patient has not gained the consciousness. So the next step is you have to deliver this baby then and there. This may be on the floor, this may be in the hospital, that is good thing, but may not be in the hospital. Okay, so how we are going to deliver this baby? Okay, that is called perimortem cesarean section. Perimortem cesarean section is patient is about to die. So we are doing this thing not to save the baby, but to save the mom. So what you do is you take a scalpel or a knife or whatever available, and you make an incision on the tummy and suddenly take the baby out. So when you remove the baby, the supine hypotension part will not be there, and all the blood will be going back to the maternal circulation, and that will facilitate your CPR process. This is called perimortem cesarean section. Okay, it's not common in obstetrics. Okay, but in my life, I have done 2 times this perimortem cesarean sections. Okay, so I was fortunate enough to do, but the patient was unfortunate. One was a twin mother, had a uterine rupture, so I had to go ahead and without wearing, you know, how do you do a surgery? You have to wear a proper gowns, you have to wear masks, you have hats and everything. But in these cases, okay, if this happened in the ward, there is no time for you to transfer the patient to theater. You have to do in the ward itself. So take a scalpel, make an incision, and take the baby out. You will be pouring with blood and all this, but you have to accept this risk. Okay, so one patient survived, one patient we couldn't survive. Okay, this is called perimortem cesarean section. So in the VIVAs, okay, this is a very important fact that you have to remember. Okay, so perimortem cesarean section. Okay, so first emergency that we have discussed so far is what is called maternal collapse. When you come to the maternal collapse, okay, you should know what is the definition of maternal collapse. Okay, then the second thing is, when there's a maternal collapse, what are the reasons? But mind you, You don't have to go behind this reason initially. What they expect from you guys is the initial resuscitation part. That's the airway. How do you secure the airway? How do you secure the breathing? And how do you secure the circulation? And this is CPR. Okay. So if there's maternal collapse, you should know the definition of maternal collapse. You should know the possible causes of maternal collapse: 4Hs, 4Ts, eclampsia, amniotic fluid embolism. Okay. And then you should know what to do. Okay. Initially, airway management, breathing management, and the circulation management. Okay. Right. And later, when the team comes, when you have more hands, then you can find out what is the reason for this the problem, whether it's hypoxia, whether it's bleeding, whether there's some toxin, and you have to manage accordingly. Okay. This is called maternal collapse. Okay, airway, breathing, circulation, and at the end, after 4 minutes, you have to go ahead and do this, what is called perimortem cesarean section. Remember, perimortem cesarean section is not to secure the baby, but to secure the mom, to safeguard the mom's life. Because the mom is always in obstetric, we pay the first attention to the mom, not to the baby. Because if a mom dies, if there's a maternal death, okay, who is going to look after the kids at home? The father may get, sometimes he may get a double bonus. He can marry another person, but the poor children at home, you can't replace the mom. So in obstetrics, the main concern priority is for the mom, not for the baby. Okay. All right. All right. Okay. So far we have discussed what is the difference between VIVA and theory when it comes to the exam point of view. Okay, then I have discussed with you, if you want to pass VIVA, what are the 3 things that you have to do? Okay, that is your confidence. You have to build up your confidence. Next thing is the ethical things, and the third thing. What is the third thing? Third thing, yes. Okay, then I discussed maternal collapse. What's the definition? What are the possible causes? How are you going to manage? Okay, right? Main things are, they will mainly concentrate on this, the initial things, airway, breathing, circulation, and these things. Okay, I will go into these steps later in detail under hemorrhages. Okay, good. All right. So now we will be going into the next topic today, one of the big topic, that is called obstetric hemorrhage. Okay, so when it comes to the obstetric hemorrhage, Daru, right? Again, depending on the time of, time of the bleeding happen. Hemorrhage means bleeding. Obstetric means during pregnancy. Okay. Again, I'm sorry. So suppose, oh, sorry. You have to apologize me for these the technical things. Okay. So suppose this is the time where a person or a patient conceives. Okay, this is up to 28 weeks. Okay, and this is the time of delivery. Okay, this is 6 weeks after the delivery period. Okay, right. So a pregnant lady can have bleeding at any of these points. That means she can have bleeding from the day of conception up to the day of delivery at any time. There's a risk. Or else they deliver, and after delivery, they can have bleeding up to 6 weeks postpartum period. Okay. So depending on the time of this bleeding happens, you can divide or you can give various names because the causes are different and the management is different. If a bleeding happen from the time of conception up to 28 weeks, okay, this is called early pregnancy bleeding up to 28 weeks in Sri Lanka. Okay, but in other countries, developed countries like the United Kingdom or in North America, okay, so the level may be up to 20 weeks because they have more neonatal facilities. But in Sri Lanka, we still go up to 28 weeks early pregnancy period. Okay, then if a bleeding occurs after 28 weeks up to the delivery, that is called antepartum hemorrhage. Okay, it's not uncle partum hemorrhage, it's called antepartum hemorrhage. What is antepartum? What is anti? Uncle's wife. No. Anti means before. Partum means delivery. Hemorrhage means bleeding. So before delivery bleeding is called antepartum hemorrhage. Okay. Then the delivery happens, and after delivery also patient can have bleeding. This is called postpartum hemorrhage. Okay. So same bleeding is coming from the vagina, not from the oral mucosa or the ear canal. Okay, we are discussing about the bleeding through the vagina, but different names. Why? The causes are different, and because of that, the management is different. Okay, so from the day of conception up to 28 weeks is called early pregnancy bleeding. After 28 weeks up to the delivery is called antepartum hemorrhage, before delivery bleeding. Same way, after delivery bleeding is called postpartum hemorrhage. Okay. In your exam, there is a very high chance that most of you guys will you will be questioned on this postpartum hemorrhage, and then antepartum hemorrhage, and few of you get cases of early pregnancy bleeding also. So very important, postpartum hemorrhage. Why it is so important? Because at the moment, okay, sorry, at the moment, in the world, the most common reason for maternal death still is postpartum hemorrhage, or a significant amount of maternal deaths are occurring because of postpartum hemorrhage. So this postpartum hemorrhage will be questioned at any part in your exam. You will get questions from your MCQs and SPS, a lot of questions, and you will get questions definitely in your emergency viva, okay, regarding postpartum hemorrhage. So very important. So we are going to discuss that thing today, okay? And early pregnancy and antepartum hemorrhage also, you will get some cases. So when it comes to the early pregnancy bleeding, that is from the time of conception up to 28 weeks in Sri Lankan setup, okay? If there's bleeding, what are the causes for this antepartum hemorrhage? Okay, causes are either, causes may be not really. Okay, so antepartum hemorrhage, early pregnancy bleeding causes are miscarriage or an abortion. The second thing is ectopic pregnancy. Ectopic pregnancy. So in your emergency vivas, okay, you will get a case regarding a miscarriage or case regarding an ectopic pregnancy. Another reason for early pregnancy bleeding is H-mall, as one of your colleagues mentioned, okay, but H-mall normally does not comes under emergency. It's because the H-malls are elective things that we deal with, but ectopics are real emergencies. Any pregnancy until proven otherwise, you have to consider as an ectopic. Okay, all right. So we will first deal with this early pregnancy bleeding, and then we will go into antepartum hemorrhage, and then we will go into the postpartum hemorrhage. Okay. So guys, when you need a break, please let me know. Okay. So then we can have a short break. Okay. Right. So I know that is quite boring to listen to these the online classes for hours and hours. Okay. Thank you. um, Hours and hours. Okay, it's not like live classes. Live classes, at least you can see that person is doing jokes and going here and there on the stage and all. But here, we all are sitting in front of the screen and looking at the screen. Okay, so it's so boring. I know that. Anyway, my voice is also boring. So please let me know. Uh, thank you, and please let me know when you guys need a break. Okay, so we'll go to this early pregnancy bleeding, Daru. All right. Hmm, right. So we'll go back to our. Sorry. We'll go back to our presentation again. Give me 1 second, 1 second, 1 second. Where's it? Yeah. Okay, right. Now, in early pregnancy bleeding, first thing I'm going to discuss about miscarriage. So please remember, Darwani, okay, when it comes to miscarriage, there are loads of the theory parts behind, but I'm not going to touch all of these things, okay, because that is not relevant when it comes to the Viva, okay. Theory students, don't worry, okay, I will cover all these things in detail, okay. So first thing, in the exam, when you go to the exam, okay, when the examiner start the discussion, they always start with, okay, tell me what is a miscarriage. So that is their favorite first question. Or what is preeclampsia? Or what is postpartum hemorrhage? So when you are studying, okay, always first thing is you have to by heart these definitions. It's very important. Okay, I think in any exam, it may be obs and gynae, it may be pediatrics, okay, it may be medicine or any other subject. Okay, so by heart these the definition, these are vital, because if you don't know the, if you know the say for example, if you know the this thing, the definition properly, okay, in a confident way, then you have scored more than 50 marks, because the examiner knows that, okay, this guy is he is a talented person, he knows the definition very well. Okay, but moment the first question, if you if you don't know the definition of miscarriage, then you will start miscarriage is miscarriage is like that, then he knows that, okay, he's he should come back to ERPM classes again next time. Like that. Okay, you know what did I mean? Okay, so definition is very important. What is the definition of miscarriage? Definition is expulsion or threat at expulsion of the products of conception before 28 weeks. That is, now during pregnancy, early part of pregnancy, the fetus, the placenta, amniotic fluid, and everything inside, we call them as, just give me this spotlight. Okay, this is called products of conception. Okay, the things inside. So miscarriage is either these products are coming out like this way. Okay, that's a miscarriage. Maybe partial, maybe complete. Okay, they are coming out. So if it is complete, you can see the cavity is nothing. This is uterine cavity ultrasound picture. Okay, you can't see any fetus inside. Okay, that is a miscarriage. It may be complete, it may be partial. On the other hand, other thing is, it can be baby still surviving inside, but there's an ongoing threat of expulsion. That is also a miscarriage. So miscarriage means either expulsion, partially or complete expulsion of the product of conception, or else there's an ongoing threat for the expulsion. This is called a miscarriage. Okay. So when it comes to the causes, okay, there are various multiple causes for a miscarriage. Okay, so that is, they will not normally ask about the causes for miscarriage. So I have given in your notes, just go through the causes for miscarriage. Okay, then what are the types of miscarriages? That is very, very important. Okay, so depending on the clinical scenario, there are various types of miscarriages. One miscarriage is, the first time is called threatened miscarriage. Okay, the first one, threatened miscarriage. So you can see the name itself will tell you the diagnosis. Threatened means baby is surviving, still surviving live inside the womb, but there is bleeding. So that means there's a threat that next time, it may be in 2-3 hours time, it may be days time, it may be weeks time, there's a possibility, not definitely, this fetus can come out. This is called threatened miscarriage. Okay, so how do they present threatened miscarriage people? They are pregnant, they will presenting with mild bleeding. It's not heavy bleeding like an open tap. Okay, they will be presenting with mild bleeding and no abdominal pain. They don't complain normally abdominal pain, but they may have small amount of bleeding, not heavy bleeding. So when you examine them from lower down vaginal examination, their cervix is closed. Why? Because the baby is still inside. Because of that, the gate is still closed, cervix is closed. Okay, and baby is surviving inside. When you do the ultrasound scan, you can see baby is still, the heartbeat you can see. Okay. Second tip is, yeah. So the second miscarriage is called the miscarriage. What is miscarriage? See the name, miscarriage. What you have missed the diagnosis of miscarriage. That is, now the patient is pregnant, okay, and she's think that my baby is growing, okay, so she's eating all these high-fi stuff, you might taking multivitamins and everything, and everybody else also thinks she's pregnant and the baby is alive inside. අල්ලපු ගෙදර මිනිස්සුත් කෑම ගෙනත් දෙනවා, අල්ලපු ගෙදර අයියත් කෑම ගෙනත් දෙනවා. ඉතින් හැමෝම සලකනවා, everybody is treating her as a pregnant lady, okay, thinking that she is pregnant, but this fetus has dead and gone long time ago, maybe 2-3 days ago, sometimes weeks ago, baby is dead inside. But there are no signs. No, normally they come to what is called the booking visit. They come for a scan. So, you know, when a patient is pregnant, they have to get done a scan. That is called the dating scan. So when they come to the scan, when you do the scan only, you can see, oh God, this baby is dead and gone. This is called a miscarriage. Normally, these people, they don't have symptoms. Sometimes they can have mild bleeding, but most of the cases, they are asymptomatic. So when you do the vaginal examination, os is closed, still os closed. Okay, right? So threatened miscarriage and the miscarriage, again, os closed. Third type is called, what is called inevitable miscarriage. What is inevitable miscarriage, Taru? Inevitable. Definitely this is going to happen. That means patient will be having more abdominal pain, more crampy pains, more bleeding. Okay, when you examine them, okay, when you do the vaginal exam, you can see the membrane is bulging out because the os is open now. In cervical canal is open now, so membrane is bulging out. Okay, baby may be still may be live or may be dead. However, since the cervix is open and the membrane is bulging out, you know, definitely this is going to come out completely. This is called inevitable miscarriage. So what is the difference between threatened miscarriage and inevitable miscarriage? Threatened miscarriage, baby is still live definitely, and the os is closed, and they don't have much symptoms. But when it comes to inevitable miscarriage, they have more symptomatic, more pain, in a bad doctor like that, right? So more pain, more bleeding. And when you do the vaginal exam, always, you know, our favorite thing is the vaginal exam. When your patient comes, we do vaginal examination as gynecologists, okay? So when you do the vaginal examination, you can see the cervix is opened. Okay, that is very important. Okay, this is called inevitable miscarriage. So threatened miscarriage, they might go into this stage or they might continue as a normal pregnancy. There's a possibility, but inevitable stage, definitely this is going to come out. So that is the third type. What is the fourth type? Fourth type is called incomplete miscarriage. You can see the word incomplete, like incomplete ERPM. Till you do your the VIVA, you will be incomplete, right? So same way, incomplete miscarriage means some of the parts came out, but some of the parts, especially the placenta and other parts, remaining inside. That is called incomplete. This is the category they can come in the exam as emergency because they can have massive bleeding and severe abdominal pain because since there are still products inside. So they will be more unstable because of the bleeding, okay, and they will have more pain. Okay, more bleeding, more pain. Okay, when you do the ultrasound scan, you can't see a baby inside, but you can see the placental parts and other stuff inside. This is called incomplete. Okay, this is the most dangerous category as far as the emergency is concerned. The next type is called complete miscarriage. So you have threatened miscarriage, miscarriage, inevitable miscarriage, incomplete miscarriage, and the complete miscarriage. How do they present complete miscarriage? Complete miscarriage means everything came out, nothing inside. So how they come? They will give you a history, doctor. Last night, doctor, it was a terrible, horrible, the abdominal pain I had, tummy pains and cramps and bleeding. I passed clots and clots, doctor. But now I don't have any symptoms, doctor. Bleeding is much settled, no more abdominal pain. Then you can ask why the HELL you came to the hospital now, because you are not symptomatic now. So the scenario is like that, okay? They are more stable. They don't have much symptoms because everything is now came out. That is called incomplete miscarriage. Okay, right? Sorry, complete miscarriage. Sorry, complete miscarriage. So those are the 5 main types of a miscarriage. That is threatened, missed, inevitable, incomplete, and complete. Okay, those are the 5 main types of miscarriages. There's another type of miscarriage, that is, in Sri Lanka, you can't abort, you can't do the abortions. It's illegal. Okay, it's completely illegal, right? So it's not ethical. So suppose now, even though the abortions or the miscarriages are illegal, you can't ban people having the sexual relationship. So there's a possibility they can be conceived. So if there's conception, and if this is, say, before, now there is a ERPM girl and boy, okay, they haven't completed the ERPM yet, they are studying, still studying, all of a sudden girl become pregnant. So can you continue this pregnancy? No, it's very difficult because of the social problems, and so a lot of issues are there, okay? So you have to terminate the pregnancy, but in Sri Lankan setup, it's not allowed. Okay, so it is not allowed to have a abortion. So what they will do, they will go under the bush, and to some person, there are some people who are doing these the abortions in Sri Lanka. Okay, so they get done this abortion, and the people who are doing this abortion, they are not using the sterile procedures or anything. Okay, so what happens is they will put some bicycle spokes, some the various stuff, okay, metal devices and various things to kill the baby inside. So what is the ultimate result? Ultimate result will be you are introducing infection into the uterine cavity. So this is a very good resource for infection. If there's organisms going into the cavity, it can infect. So when there's infection, it can spread all over the body, and the patient will be septic. Patients will be going into what is called septic shock. Okay, so this scenario is called septic abortion. Okay, septic abortion. Or in medical legal point of view, they will say criminal abortion, criminal, right? So this is the last type of miscarriage. So at any stage, you can have a criminal or a septic abortion. This is another emergency that you will see in your day-to-day practice. Okay, so these are the, so far I have discussed with you all, okay, I have discussed with you all uh, uh, the definition of miscarriage and what are the types of miscarriages, that is miscarriage, threatened miscarriage, inevitable, incomplete, complete, and septic miscarriage or septic abortion. Okay, and these are the differences between these types. So how do the people with septic miscarriage comes? Do they come and tell you, doctor, I am pregnant, mamma එක ගිහිල්ලා කරගත්තා කියලා? No, they will not tell. When you ask from them, do you know that whether you are pregnant? No, doctor, no. Me corona හැදිලා මීටර එක distance එක තියාගෙන හිටියා, husband දැක්කේවත් නැහැ. The moms, sometimes moms are coming with the kid, the child, and tell, නෑ doctor මෙයා පිරිමි ළමයි එක අතින්වත් අල්ලලා නැහැ, like that, something like that. අතින් අල්ලලා නැහැ. Maybe correct. Okay, so they completely deny pregnancy most of the cases in Sri Lanka. But in other countries, I mean, it's not a big problem. They will come and say, yes, I'm pregnant. I'm pregnant, like that. But in Sri Lanka, they completely deny a pregnancy. So they will not give a history of pregnancy, but when you do the urine pregnancy test, it's positive. And they will have all the features of sepsis, such as fever. They will be feverish, and they will be ill looking. Like then මේ class එකේ ඉන්න ළමයි වගේ දැන් එපා වෙලා ඉන්නේ දැන් මේ class එක is continuing and continuing and continuing boring class. Then the kids are like, students are like එපා වෙලා ඉන්නේ. Right? Like that, they will be ill looking. Patients with septic miscarriage, they will be ill looking. Fever, ill looking. They will be tachycardic, and their blood pressure is very low because of the septic shock. Okay. And when you examine from lower down, the vaginal examination, when you put a speculum, there's a smelly discharge coming out. Okay. It's a very, very, very smelly discharge. A patient with septic miscarriage, when they are coming into the room, you can diagnose septic miscarriage from that distance. That's smelly. Okay. Because this material, this septic material is very smelly because of the anaerobic organisms. Okay. So those are the features of septic miscarriage, right? So when you come to the management point of view, Daru, miscarriage management, you all know that there are three options: expectant management, medical, and surgical management. What do you mean by the expectant management? Expectant management means you don't do anything to just allow the nature to cure the problem. If the girl is, say, for example, say a nice, pretty lady coming with a miscarriage, you diagnose the miscarriage. And if the patient is stable, you can just observe the patient. Okay? Observe the patient, because over the time, the things will come out completely. So you don't have to do anything. This is called expectant management. To do that, patient must be stable. It's not an emergency. Next step is, rather waiting for the nature to cure the problem, you can use tablets to make the management of miscarriage. One of the tablet is called misoprostol. Remember, this is the most important point today's class. Misoprostol. You can use misoprostol to manage or to create or to complete a miscarriage. Write down the name is misoprostol. Maybe import in future. Right. So you can use the medical management for a patient who is having a miscarriage. But remember, again, to the medical management, patient should be to some extent stable. If the patient is having massive bleeding and unstable patient, low blood pressure, tachycardia, then medical management has no role. So in case of emergency, the main thing is the surgical management. That is, you take the patient to the theater under anesthesia, you suck out or you drain or you pull out all the contents inside. Okay, that is called surgical management of miscarriage, or evacuation of retained products of conception, or is called ERPC. Okay, ERPC, evacuation of retained products of conception. So in your emergencies, right, normally if there's emergency with a miscarriage, we normally do this thing. Okay, right. So, right. So I'll go into the clinical scenario. Okay. Yeah, we'll discuss the clinical scenarios here. Now, suppose patient is coming with, okay. Now you are the honorable house officer in the ward. Okay, honorable house officer. Okay, right. So you are doing on-call shift. There's a patient coming to your say at night, middle of the night. Okay, so you are in the hospital in the ward. There's a patient coming with, say, patient is complaining of severe abdominal pain and bleeding. Okay, so when you go through the patient's records, there's a scan report that patient is before pregnant, and there's an intrauterine pregnancy that was confirmed with the previous scan. Now she's coming with a severe abdominal pain and bleeding. So what will you do first? Patient is coming with severe abdominal pain. Patient is very, it's not a very well-looking patient. Patient looks unstable. Okay, heavy bleeding, severe abdominal pain. What will you do first? So in the exam, you have to tell, sir, I would consider this thing as an obstetric or gynecological emergency. I will attend fast. Okay. So what will you do first? You have to go in that order: airway, breathing, and circulation. Okay. So when a patient comes like this, these patients usually their airway is patent, because as long as they are conscious, their airway is patent. So you just have a chat with the patient, like, amma ඔයාගේ නම මොකක්ද, like that. කොහෙන්ද ආවේ, like that. If the patient is answering, if the patient is communicating with you, that means the airway is okay. So you don't have to worry in that case. So you don't have to do the triple maneuver. මේ හොඳට හුස්ම ගන්න මනුස්සයගේ triple maneuver කරන්න යන්න එපා. Okay. So you know that now the airway is okay because the patient is conscious. Second thing is the breathing. Patient may be breathing like, "Amari doctor, body හැක්කුම අම්මෝ bleed වෙනවා හොඳටම." Um, um, like that. Okay. That means what? Patient need oxygen. So give oxygen via a face mask. Mouth breathing never give it out. Okay. So give oxygen via a mask. Okay. So airways, you have assessed patient airways okay because patient is conscious, and to facilitate the breathing, give oxygen. Okay. Third thing is, okay, then the circulation is the main thing. So what you have to do is quickly check the pulse rate and blood pressure. Say pulse rate is 130, low volume pulse, blood pressure is 70/50. So what does that mean to you? Patient is in a hypovolemic shock state. Okay. So what will you do? Okay. Now you are with the patient. So you are the boss now till the experts come, or till the team comes. You are the expert now. Okay. So you order all the other people. Okay. Right. So you order the other people. Okay, means me at a cannula එකක් දාන්න. Ask them to put a cannula. You have to ask the nurses to put 2 wide bore cannulae. Why you put 2 cannulae? If one cannula going out, then you have additional extra support. Okay. So ask them to put 2 wide bore cannulae, and same time take blood. When you're putting the cannula, you can take blood. Take blood and send blood for cross matching, because you need to transfuse this patient. So send blood for cross matching. Okay. And you can do a full blood count to assess the hemoglobin level also. Okay. So what you are going to do, first quickly ask few questions from the patient and assess the airway. If the patient is conscious, airway will be okay. Then to facilitate breathing, give oxygen, high flow oxygen via a face mask. Then assess the pulse and the blood pressure. I'll ask the nurses to put 2 wide bore cannulae. Okay. So ask them to put 2 wide bore cannulae, and same time take blood for cross matching and hemoglobin assessment. Okay. And send this blood for cross matching. Okay. And then when you send the blood for cross matching, just give a call to the blood bank Aki and tell Aki, I have sent a blood pint of a patient who need urgent transfusion. Otherwise, they will take years and ages to cross match this blood. Tell them that this is urgent. Okay. Send blood for cross matching. And how long it will take for the cross matching? It will take at least about 20 minutes. So can you wait till 20 minutes till the blood is available? No. Till the blood is available, you can put them on, you can start them, whatever the fluid available in the ward. What are the fluid available in the ward? Yes, you can start crystalloid like normal saline, Hartmann's. So give fluids not drop by drop. You have to give fluid fast. So squeeze it and send them fast. Okay. Squeeze what? Squeeze the bottle and send them fast, not just drop by drop. So give fluids, okay, and send blood for cross matching. And you doing this. This is also kind of a resuscitation. So you have given oxygen. Now you are giving fluids, and when the blood is available, you can start the blood transfusion. Now, meantime, you have to assess the patient from top to bottom, okay, and do a vaginal examination. If the OSCE is open and if there's a continuous bleeding, then you have to discuss with your seniors and take the patient immediately to the theater for emergency evacuation of these products. This is called ERTC. So before you send the patient to the theater, you have to make sure that you resuscitate the patient in the ward before you send to the theater. Because unstable patient, if you just send to the theater, then the outcome is not that good. So what you have to do is give oxygen, okay, and ask the nurses to put white bore cannulae, 2 white bore cannulae, send blood for cross-matching, start fluids fast. And meantime, inform your seniors that there's a patient like this, so we will have to take him to the theater. So immediately take the patient to the theater and arrange for emergency evacuation of the products. Okay, right? So that is the management. I will go all these steps in detail with postpartum hemorrhage. Okay, don't worry. I'm just putting the foundation for that. Okay. Right. So what are the things we have discussed so far? We have discussed the maternal collapse, and I have introduced what is obstetric hemorrhage. Up to 28 weeks is called, these are the reason, miscarriage, ectopic and all. Okay, after 28 weeks, antepartum hemorrhage, and after delivery is called the postpartum hemorrhage. Okay, sorry. Under early pregnancy bleeding, okay, miscarriage, the definition, what are the types of miscarriages, okay, and then we discuss incomplete miscarriage, how we are going to manage the patient. Another scenario, a patient comes to you, okay, complaining of abdominal pain and fever and a smelly discharge. Okay, she denies pregnancy, no pregnancy at all. Like that, patient totally denies pregnancy. But when you check the urine pregnancy test is positive. And when you examine the patient is ill looking, feverish, tachycardic, blood pressure is low, okay. um, blood pressure is low, and when you apart the leg, there's a smelly discharge coming. What is your management? What's your diagnosis? This is until proven otherwise. This is septic abortion. Okay, septic abortion, your management is mainly because there's a sepsis going on. You have to treat the patient. So again, you have to go airway, breathing, and circulation. If the patient, assess the patient, if the patient is talking with you, that means the airway is okay. The next step is the breathing. Again, give oxygen via a face mask, high flow oxygen via a face mask. Okay, airway, breathing. Then the third thing is the circulation. Again, ask the nurses, always get the nurses close to you. Okay, ask them to put 2 white bore cannulae, send blood for cross matching. And not only that, Daru, in this case, you have to do, because you are suspecting sepsis, you have to do what is called septic screening. What are the septic screening? You have to do a full blood count. You have to do a CRP, okay, to see an infection, CRP, and you have to send blood cultures, urine cultures, and a vaginal swab for cultures. Okay, so because you need to identify what is the organism which causing this problem. Okay, so take all the cultures, full blood count, CRP, okay, and then you send to the lab. So how long will it take for this culture to be available? We don't know. It will take long time, at least 48 hours. Meantime, since the blood pressure is low, again, you have to start them on the you have to start them on the fluid, give fluid fast, okay? And once you have taken all the cultures, you have to start them on broad spectrum antibiotics. What do you mean by broad spectrum antibiotics? Broad spectrum antibiotics means it should cover gram positives, gram negatives, and it should cover gram positives, gram negatives, and anaerobes. Okay, so you have to start antibiotics. What are the examples that you can start antibiotics? What antibiotics you can start? Okay, so you can start coamoxiclav. Don't say augmentin in the exam. Okay, that's a failure. Augmentin is not the generic name. So coamoxiclav. You can start coamoxiclav, metronidazole, and gentamicin, also very important. Okay, severe septic patients, better to start gentamicin because that is really effective. Okay, start gentamicin as well. Okay. All right. Okay, so you start antibiotics, you give fluid and resuscitate the patient. Like incomplete miscarriage, Daru, you have to, once you resuscitate the patient, you have to take the patient immediately to the theater. But in septic miscarriage, normally we don't intervene surgically. Why? The doses you don't have to remember, Daru. Okay, don't worry about the doses, antibiotic doses. Okay, the emergency other drugs like syntocinon, ergometrin, the misoprostol, and all the doses I will tell you later. Okay, in PPH management, but antibiotics doses you don't have to know. Okay, don't worry. Okay, so what I was telling you, yeah, in incomplete miscarriage when there's a bleeding. When there's bleeding, okay, you have to take the patient to the theater and surgically evacuate the things. But in case of a septic miscarriage, we don't rush and do ERPC. Why? This womb is already, it's womb is already infected. When it is infected, it's very fragile. Okay, so when you insert this instrument into the uterine cavity, it can easily perforate the uterine cavity like this. Okay, so when it is perforated, you can get a lot of complications because the bladder and bowel and all the structures are close by. So ultimately, your histology will come as like, rather than retained products, your histology will come and say, okay, there's a liver biopsy, there's a bowel biopsy, omental biopsy. Why? Because you have damaged these structures. Okay, so the patient will not survive up to that level if there's a damage. Okay, so what I want to tell you is if there's a septic miscarriage, you treat them with antibiotics and the fluid. Once the infection is settled down later, if necessary, you can go for a ERPC. Okay, so please remember, okay, in septic miscarriage, don't offer surgical management as the first line. It's the conservative management with antibiotics, fluids, and later, if you want, if there are persistent products, you can remove them surgically. Okay, so regarding the miscarriage, as emergencies, you can get two kind of miscarriage. That is incomplete miscarriage with bleeding patient, unstable, or else other thing is you can get a septic lady, a septic miscarriage, coming with all these symptoms, and they might ask you the management. Okay, right? So I hope you got some idea about this miscarriage management, emergency management. Okay, right? So you have to tell, I will consider this thing as an obstetric emergency. I will attend urgently. I will have a chat with the patient. If the patient is conscious, her airway is patent, then I will, if the patient is in septic condition, I will give her oxygen via a mask. And then I'll ask the nurses to put 2 white bow cannulae, send blood for cross matching. I'll take the septic screening and start them on broad spectrum antibiotics in case of a septic miscarriage. Okay, clear? Okay, all right. So do you need a break now before we go to the ectopic, or shall we finish the ectopic also and go to the break? Is that okay? Okay, thank you. Yeah, we'll get the break after the ectopic. Okay. All right. So where are we now? In front of the screen? No. I'm asking where are we now in the process? Okay. Sorry. What happened? Yes. Now we have discussed the early pregnancy bleeding. Under that, we have discussed this miscarriage. Then come to the ectopic pregnancy. What is ectopic? What do you mean by ectopic? It may be ectopic beat on your heart, or ectopic pregnancy, or ectopic. What is ectopic? Ectopic means something is not in the usual place. When something is not in the usual place, it is called an ectopic. Okay. So when it comes to the pregnancy, what is ectopic pregnancy is, right? Now, this is the uterus, this is the tube, this is the ovary on one side, the cervical canal. Okay. So normally the pregnancy should be here. Okay. So intrauterine pregnancy means pregnancy should be within the uterine cavity. Due to some reason, if the pregnancy is sitting outside the lining of the endometrial cavity, okay, outside the lining of the endometrial cavity, that is called ectopic pregnancy. Outside the lining of the endometrial cavity. This is the lining of the endometrial cavity. Okay. Anything outside that is called ectopic. So if there's a pregnancy sitting on the cervical canal, it's an ectopic, cervical ectopic. If it is on the tube, along the tube, anywhere along the tube, that is called an tubal ectopic. It may be sometimes on the ovary, ovarian ectopic. It may be inside the abdominal or the peritoneal cavity, abdominal ectopic. Where else you can get ectopics? Can you get ectopics in the stomach, esophagus, in the gut? Unlikely, isn't it? Ectopics you can't get on in the esophagus or the stomach or in the GI tract. Okay, so outside that is possible. Anywhere, sometimes under the diaphragm, under the liver, covered with omentum, on the ovary, anywhere it is possible. Out of all these places, the commonest site is on the tube. This is called the tubal ectopic. This is the commonest site. Okay, so majority of ectopics you will get in the tube. Again, the causes for ectopic and all I have given in your note, I suppose. Okay, just go through them because they will not ask these things in the emergency VIVA. But here, students, you have to know. Okay, but I will go into detail with you guys later. Okay, right. Right. So ectopics, when you come to the ectopic can present in two ways. One is unruptured ectopic. Other one is ruptured ectopic. Okay. In these pictures, try the ultrasound picture. Okay. This ultrasound here, it clearly shows this is the uterine cavity. Okay. You can see outside the uterine cavity, there's a pregnancy. This is a typical picture of a ectopic, which is still not ruptured. So unruptured ectopic is not that kind of a emergency because it's an elective procedure. However, this is the second scenario where the ectopic can present as an ruptured ectopic. You can see here, the chocolate colored one, all this is blood. This is the uterus here. It's deep seated within the blood pool. Okay, the bowel loops are floating. So this is a real emergency. This is called ruptured ectopic. What is the incidence of ectopic pregnancies? It's 1%. That means if 100 girls or 100 ladies conceive today, one would be ectopic. Be careful, okay? Right? Don't become pregnant before ERPM. These are another pictures of ruptured and leaking ectopic. You can see here. You can see here, okay, this is the ectopic, the tube. Okay, you can see the dilated tube. This is the womb. Okay, this is a laparoscopic view. You can see the blood clots there. Okay, this is another picture. This is a uterus. This is a normal side. Okay, and you can see the ovary, normal ovary. And this is the ectopic on the other side, on the left-hand side. Okay, so right. So when it comes to management of ectopics, again, like miscarriage, same scenario. Okay, same thing. Okay, you have three options. One is expectant management, one is medical management, one is surgical management. You may be wondering, can you manage ectopic as an expectant management without doing anything like a miscarriage? Yes, there's a possibility. Because if the ectopic is not growing, and if there is no evidence of rupture, if the patient is stable, you can offer them expectant management. Okay, So in the emergency, you don't have to know in details, but generally, okay, expectant management means patient is not symptomatic, no abdominal pain or anything. There is no evidence of leak, okay, and the HCG levels should be low. Ideally, should be below 2,000 or 3,000. Okay, in that scenario, you can, without doing anything, you can just wait and see. Naturally, what happens is this baby or the fetus is going to die and absorb into the circulation. Second option is called the medical management. Medical management is, rather than spontaneous waiting, you can give methotrexate, initially misoprostol for the miscarriages, but ectopic, you can give methotrexate to kill the fetus, ectopic set. For that also, patient should be stable and there should not be evidence of leaking of blood. This is the commonest thing that we do in ectopic pregnancies, that is called the surgical management. Okay, surgical management. If I go to the whiteboard, I can draw you for you all. Okay, so suppose this is the ectopic on a tube, okay, and these are the ovaries on either side, okay, right. So when it comes to the surgical management is usually the first line management of ectopic. It's not like miscarriages, okay. So surgically, what we do is you go into the tummy, okay, into the tummy, and you have a look. Now, suppose the patient, okay, this is endometrial cavity. So you identify the ectopic, and meantime, you have a look at the other side. If the contralateral side is, or the other side looks normal, what you normally do is you remove the ectopic and the tube together. So you go into the tummy, you go into the tummy, okay, and then have a look inside. If the other side tube looks normal, don't worry, you remove whole tube with the ectopic sac out. That is called self-injectomy. Self-injectomy. Okay, removal, ectomy, appendicectomy, like that, cholecystectomy. Okay, so like that is called self-injectomy, removal. You remove the you remove the whole tube with the sac. That is one option. Other option is, okay, suppose other option is you go inside, and when you have a look, the other side tube also damaged. Oh, sorry. Come on. Okay, other side tube is already damaged. Last time also she had ectopic and that side was removed. Okay, so this is the normal side. Now you are having ectopic. So what you do is, in that case, if the patient has not completed the family, what you do is you make an incision here and take the ectopic out and leave the tube intact. This is called self-ingotomy. You are not removing the tube, because if you remove the tube, okay, then there is no way this patient can conceive for the next time. Okay, so what you do is you just remove the ectopic sac, leaving the tube intact. This is called self-ingotomy. Self-injectomy means you totally remove it. Self-ingotomy means you remove the ectopic only. So you may be wondering why the HE-double-L, you are removing the whole tube rather than removing the ectopic only. The problem with this procedure is, removing the ectopic only procedure, self-ingotomy procedure, is if you remove them, the next time also there's a higher chance patient can get another ectopic on the same side. That's why we always usually remove the disease side, leaving the other side. But of course, if the other side also damaged, if the patient is having fertility issues, you can't remove everything. Because everybody is not affordable for the IVF. So what you have to do is you take the risk and you remove that ectopic while keeping the tube intact. Okay, this is called self-ingotomy. Okay, so ectopic surgical management, we have three options for ectopic management: expectant, medical, and surgical. But in ectopic cases, the first line management is surgical management. For you to do this expectant or the medical management, patient should be stable enough. Okay, but emergencies, you will get this scenario, that is where you have to do the surgical management. Surgically, you have two options, either self-injectomy or self-ingotomy. If the contralateral side tube is normal, you go for self-injectomy. If the contralateral side also damaged and the patient wants children, you just remove the ectopic, leaving the tube. It's called self-ingotomy. Okay. Then there are two surgical approaches for this. One is laparoscopy. Laparoscopically, you can do the surgery. Other thing is you can do this surgery laparotomy. Laparotomy. What is the difference between this laparoscopy and laparotomy? What's the difference? Laparoscopy means you all know that. Okay, laparoscopy means, sorry, with the camera, with the tiny camera, tiny camera, you do the surgery. Okay, so what is the advantage of that? Advantage is, this is the tummy. Okay, so patient will have very small 2 or 3 scars on the tummy. They are very tiny. Okay, so they can wear the sari up to the mid-thigh level if they want, because there are no scars there. Okay, cosmetically more sound, and the recovery also fast with the laparoscopy, because it's a minor, the small incisions. Okay, there's no problem with the cosmetic aspect, the scars and all, so they can wear anything, right? The rings and anything, and they can wear the sari up to the mid-thigh level if they want, because there are no scars. On the other hand, if you do a laparotomy, there will be a scar on your tummy like this. Okay, so ectopic, most of the cases we manage laparoscopically. However, if the patient is coming with a massive bleeding, yes, if a patient is coming with a massive bleeding, okay, if a patient is coming with a massive bleeding, then you can't, because laparoscopy, it takes some time. Okay, so in that case, you can't wait. If a patient coming with a massive bleeding, you can't waste your time. Sorry, if a patient coming like this, sometimes even worse than this, okay, massive bleeding inside, in that case, you can't think about the cosmetic aspect, but you have to survive the patient. Okay, so in that case, you go ahead and do laparotomy. Laparotomy means you take a scalpel and you can do a surgery quick as possible. Okay, but the laparoscopy is a fine surgery, it takes time, but laparotomy you can do fast and you can relieve the problem. Okay, so in ectopic management, okay, if a patient is coming with ruptured ectopic, most likely they go for laparotomy. Ruptured ectopic, unstable patient, best option is laparotomy and self-injectomy. Ruptured ectopic, however, if the patient is bit stable, pulse rate is okay at the moment, blood pressure is okay at the moment, in that case, you can consider laparoscopic surgery, self-injectomy or self-ingotomy. Is that clear? So, ectopic can present in two ways. Unruptured ectopic, patient is asymptomatic, whereas ruptured ectopic. Ruptured ectopic, you don't consider either conservative or the expectant or a medical management. Only way to manage is by a surgery. There are two modes of surgeries, either laparoscopy or laparotomy. How do you decide? If the patient is unstable, go ahead and do a laparotomy. Don't think about a scar. If the patient is stable, However, there is bleeding inside, but the patient is stable at the moment, then you can consider laparoscopy. Okay, either laparoscopically or laparotomy, what you will do, self-injectomy. However, if the contralateral tube is damaged, already damaged, you go for self-ingotomy. Otherwise, almost all the cases, self-injectomy. Okay, right. Now, suppose a patient, say young patient, 25 years old student, not ERPM student, say, ERPM student, is a 25 years old local medical student. Okay, right. A local medical student coming with severe abdominal pain. Okay, just go there. Yeah. Okay, right. So suppose a 25 years old young lady, young girl coming with severe abdominal pain. Bleeding may be there or may not be there. What are your differential diagnoses? Okay, right. So we go to the whiteboard again, right? So there's a patient, say 25 years old, very young patient, okay? 25 years old patient. Patient may say that, doctor, I had my period last month also. May not be a period of amenorrhea. Maybe, may not be, not necessary. Okay. 25 years old, young patient coming with severe abdominal pain. Abdominal pain. Okay. What are your differential diagnoses, Taru? What is the first thing? Until proven otherwise, any woman coming with abdominal pain, first thing is ectopic pregnancy. Ectopic pregnancy. Remember, okay, even Archie comes, Archie laganan samani karan onne, but you know, any woman coming nadi betena ona manusik avot ehema with abdominal pain, female, first thing is ectopic. You must exclude ectopic first. Okay, what else can it be? It can be ovarian cyst accident. Ovarian cyst accident. Suppose there is a ovarian cyst, okay? There's ovarian cyst on this side, okay? So sometimes, most of the cases, yes, these cysts are not symptomatic. However, you know the way the girls are walking, okay? So when they walk with this you know, the catwalk, when they do this catwalk, the cyst also will be pendulating from one side to the other, one side to the other, one side to the other. So what happens? At one point, this thing can twist. Okay, at one point this thing can twist, and which can cause severe abdominal pain. So that is a possibility. Ovarian cyst accident is a second possibility. What else can be? It can be ectopic, ovarian cyst problem, or else maybe non-gynecological, like surgical hematoma. Okay, so it may be, yeah, appendicitis normally do not cause acute pain, sudden pain, but possible urinary stones, gallstones. Okay, so these things also can cause pain, any surgical causes. Okay, so any patient who's coming with severe abdominal pain, first thing is ectopic pregnancy. Until proven otherwise, it's an ectopic. So you need to exclude ectopic. Okay, so suppose 25 years old, local medical student, not a ERPM student, not a ERPM student at all. Okay, they don't get ectopic. Okay, local student coming with severe abdominal pain. Okay, when you examine the patient looks pale, pulse rate is 130, blood pressure is 70, or say 90/60. Okay, when you touch the abdomen is very, very tender abdomen. Okay, very tender abdomen. Then when you check urine HCG is positive. So what is your first differential diagnosis? It is until proven otherwise, it's an ectopic. Okay, so then you do an ultrasound scan, right? The scan may show the blood in the abdomen. So that is highly suggestive of ruptured ectopic. So how are you going to manage this patient? So the examiner will tell you a story like, okay, this 25 years old lady coming with severe abdominal pain, okay, and severe tenderness on the abdomen, pulse rate is 130, blood pressure is like this. What is your first thing? You have to tell them that, so this is a real emergency. So I would consider this thing as ruptured ectopic until proven otherwise. So what will you do next? You ask them to do a urine ECG. If it is positive, this is more likely ruptured ectopic. Then how are you going to manage this patient? So then you have to tell again, this is an obstetric or a gynecologic, whatever it is. Sorry, emergency. Okay, so I will assess. I will have a talk with the patient. If the patient can communicate with me, airway is patent. Don't always say I will do A, B, C. That is very typical way of presenting the thing. Okay, you can just say, rather than saying that, you can say I will assess the airway by talking to the patient. If the patient is conscious and patient can communicate with me, airway is patent. So airway is okay. Then patient may be grasping like, sorry, doctor. Uh, uh, this is the writer in the board, right? Um, um, like that. Okay, then what you have to do? Give oxygen via a face mask. Same thing, oxygen. Then most thing is the most important thing is the circulation. Assess the pulse rate and blood pressure. Pulse rate is high, blood pressure is low. So you know the patient is having hypovolemic shock state. So what you have to do, ask the nurses to put two white bore cannulae and send blood for cross matching. Very important. Ask them to send blood for cross matching. Okay. Meantime, you have to inform your team because you suspect this is an emergency, real emergency you can't manage alone. You have to inform your the colleagues or the team. To whom are you going to inform? You have to inform your seniors. Who are the seniors, right? You have to inform your the SHO or a registrar or even the consultant. Some consultants sometimes may be doing ERPM classes. So, but anyhow, he also has to go and attend the case. Okay, inform your seniors. Who else you need to inform? Again, inform the blood bank Akki. Tell her that, okay, Akki, there's a patient with ruptured ectopic. We need blood urgently. So Akki will come from somewhere and do the cross matching fast as possible. Okay. Third thing is inform the theater team because they also have to, this is a real emergency. They also have to get ready for this emergency. So inform them and inform the anesthetist also. Okay. To who else need to be informed? Please, boys, please inform your girlfriend also. Otherwise, she will be keep on calling you, calling you. Mokada karane tamse mechare la mokada reply nete arakai make like that. So inform her. I'm going to manage a topic. Don't wadayak wenni pa kiyana එක just tell her. Otherwise, you will be in trouble. Okay, so inform all these parties and get ready for the surgery. Okay, so ask the nurses to put two white book and you will send blood for cross matching until the blood is available. You can give fluids, IV fluids, send them fast. Okay, like normal saline, Hartmann's, or whatever available, you can give fluids. Okay, when the blood is available, you can start giving the blood, and then take the patient immediately to the theater for emergency surgery. Okay, so the basic things for anything, either miscarriage or ectopic or anything, the basic things are the airway, breathing, circulation. Okay, this is how you manage ectopic pregnancy, ruptured ectopic pregnancy. Okay, clear? All right. Okay, so right now we have discussed in the obstetric emergencies today. We have discussed the maternal collapse and early pregnancy bleeding problems, how we are going to manage as emergencies, right? Like miscarriages, incomplete, septic, and ectopic management. Okay, so now I think you all can have a break, small break. Is that okay? Right? I don't mind. I can continue, but I think it's better to have a 5 minutes break and then we can rejoin. Is that okay? Guys, can you all hear me? I think yes. Yes. So, sorry. Where's my presentation? Wait. Okay. So meantime, uh, you can yes. If you all have any questions, yeah, I'm happy to discuss during this time, and you can have 5 minutes break. Now it is 10:53. We can restart at 11. Is that okay? Yes. So we will restart at 11. Meantime, I can answer your questions if you all have. Yes. Okay. Right. Okay, we are going to restart at 11, sharp at 11. Okay. Yeah.
So you're mute, sir.
Unmute. Can you hear me now? Yes.
Yes, sir.
Yeah. So sorry. So I'm not convenienced with this the setups and all. Okay, I'm really sorry. So from the next class onward, it will be more well organized. All right. So somebody asked about can we give methotrexate for ectopic pregnancies if the fetus is live? Yes. Answer is yes, because when you give methotrexate, they will kill the placental cells. Okay, so ultimately the baby is going to die. But on the other hand, Daru, the success rate is less. So ideally, if you're planning for methotrexate, it's better if the beta hCG levels are not rising. That means fetus is dead. For a live fetus also, you can try, but the success is less. All right. Um, Yes, somebody asking regarding the miscarriage management scenarios. Do we have to do the speculum examination before the ultrasound scan? Yes. Now, any patient management start with the history, examination, and then investigation. Yes. So when you come to the examination, you have to. Thank you. You have to first do your full clinical examination. So in gynecology and obstetrics, full clinical examination include vaginal examination by manual as well as speculum examination as well. Yes, that's true. So don't worry about the speculum examination and vaginal examination and all. Okay, I will cover these things in my latter part, so you don't have to be worried about these things. Those are not big issues. Okay, because the cervix is there, vagina is there. You are just putting this gadget to the vagina, so you should be able to see the cervix. So it's not a big issue. So those are not big issues actually. Let's see any more questions. Uh, uh, uh. Yes. Thank you all. Mm, mm. Yes, somebody is asking. Uh, Yeah, somebody is asking in incomplete miscarriage management, can we use misoprostol before we go into the theater? Yes, you can use misoprostol. However, if the vegetation is having continuous bleeding, better to go for, you can put misoprostol, but don't wait. Better to take the patient to the theater and do the procedure as soon as possible. But no harm putting misoprostol. You can try misoprostol as well, but it's always um, better to go ahead and do the procedure. Mhm. Can you please provide the note maternal collapse? Is it not there? Maternal collapse notes are not there in the note. No. Okay. Sorry. Yeah, I can give you next time. I'll. It's a small note. I mean, uh, I thought it was there. I'm sorry. So I'll provide you a note. Don't worry. Okay. It's very boring to do these online classes, isn't it? I mean, if you are doing live classes, you are live, and you can see, I can see your faces, and it's more. I mean, it the faces itself give some feedback. You will be like, oh, and then I know that I have to stop the class. But when I'm doing these classes, but I can't get that impression, and it's so boring. I know that. Yeah, next emergency class, the second part of this, I'm going to do soon. Okay, so the problem is this time slot, because I have started late. Mandapama kila samahara ay ahano, Mandapama, because I was not in the country. So uh, I'm finding it difficult to find the time slot. So I will do it within this week. Don't worry. Okay, I will do it as soon as possible, and I'll keep you guys informed through my Telegram and the other groups. These days, I mean, there is nothing else to see. So we used to see this, watch this series. What is that called? Teens, not teens, voice. Yes. So I'm a fan of Kumari as well. Yeah, that's true. Voice teens, yeah. Voice teens and voice, yes. So at the end of this session, I'm, I'm, uh, I'm happy if you all can give some comments and feedback. Okay, you don't have to say that it's awesome, and I know that's not awesome with this technical problem and all, but give some comment. I mean, what are the things that I need to improve, and if you think this way is good or like that, give a genuine comment. Okay, so then I can improve myself. All right. So I think most of the now it's 11 plus 1. I think um, so we can restart, isn't it? Yeah. So regarding this Viva session, so I'm going to do and I mean, when we start the classes, the Vivas, the sessions, so I'm planning to do 9 more classes on Viva, okay, which covers your full syllabus, okay, 9 more classes, okay. So so by mid March, I'll be able to finish your syllabus, okay. These Viva classes I'll be conducting um, on the regular gynae and ops dates, okay, mainly Thursday and Saturday on our gynae slot, okay. So I'll be conducting these classes, and I'll try my best to arrange some hospital visits for you guys also. And I will do um, meantime I will do some demonstrations to, like, in this way I will do some demonstration. I will not show you all the vaginal examinations live and live stream and all these things. Those are highly unethical things. I will not do them. Okay. But I will make sure that before you go to the exam, you are thorough with your vaginal examination. And you are thorough with the vaginal examination and this speculum and the instruments necessary. Okay, forceps, vacuum, and other necessary instruments. Okay, so don't worry about those things. I will do them. Okay, for a sure. Okay, and I will train you all how to do a presentation properly. Okay, that is very important when it comes to the Viva. Okay. And with regarding to the charges and the cost, okay, so it will be a more favorable charge in the sense it will be lesser compared to the other people. Okay, so I'm not going to charge any additional things, and there is no dragging because I believe in 9 classes I'll be able to finish the syllabus. I have done it before, so don't worry about it. And the people who want to make the full payment will get some discount. Okay, anyway, I'm charging a lesser amount, and those who can't do that, as installments also, you can make the payment whatever the way. Okay, so ultimately the best thing, good thing is, you have to get my message, and you have to, at the end you should succeed in the exam. That is my main purpose. Okay, so if somebody is having some financial difficulty or anything, you can have a chat with me personally. Okay, so I can arrange some things for you guys. All right, so the schedule, I'm going to put the schedule soon. Okay, either today or tomorrow. And there will be 9 more classes, Viva classes, and so that will cover everything. For the theory students, okay, I'm going to start the theory classes also soon. Okay, then you can join, and I'm going to cover the full syllabus and the revisions as well. Okay, so you can join with the theory also. All right, shall we go to the antepartum hemorrhage? Sorry. Oh, sorry. Hello, Mother. Wait. Student, just give me 1 second. Something went wrong. Okay, Daru. Sorry. Yeah. Right. Okay. So the people who are registered, we are going to arrange a register, attendance register. Okay. For those who wants to attend, you can attend, and people who are attending one time, so they don't have to pay again for the next time if they are coming in future classes. If they are coming, they don't have to pay again. So once you pay, that's all. So you don't have to pay again. Okay. And the schedule and the timetable I will keep you all. Okay, so sometimes I might have to put a class on Friday, but I'll tell you in sure when I'm going to do the classes. Okay, right. So we will go back to the session again. Sorry. Yes. Right. So we have discussed all these things. Now, Bandalat Tivarai, then now we are going to the second part, that is called the antepartum hemorrhage. Okay. So what is antepartum hemorrhage? Before delivery bleeding. Okay. When it comes to the antepartum hemorrhage, there are various causes. Okay. And out of that, as far as the emergencies are concerned, there are two main the things that you have to know. Bleeding occurs after 28 weeks before delivery is called antepartum hemorrhage. One of the common reason is called placenta previa. Placenta previa. What is placenta previa? Placenta means placenta. Previa means, what is previa? Previa means priyaginangi. That is previa. Previa means in Latin is called low. So low placenta is called placenta previa. Okay, when the placenta is in the lower segment, that is called placenta previa. So if I demonstrate here, okay, so here, Daru, you can see, sorry. Now this is the womb, okay, you can see the baby inside. This is the placenta, and this is the umbilical cord, okay. Normally, this placenta is attached to the upper part of the uterus. It's also called upper segment, okay, this part, okay. But when the placenta is lying in the lower segment, this is called placenta previa. So the definition of placenta previa is placenta is locating in the lower uterine segment. Okay, like this. So why we are worried when the placenta is sitting in the lower uterine segment? Because yeah, because when we sorry, I'm sorry about this thing. Yeah. So if I go to the whiteboard, okay, I'll draw and show you. This is the uterus, okay. This is the inside wall, okay. The bladder is attached somewhere here. This is where the bladder, this is the anterior aspect, this is the posterior aspect, okay. Baby is inside, okay. Now this line, this is an arbitrary line, okay. Ultrasonically you can see it. The part above that is called the upper segment, whereas part below that is called the lower segment. So this is the lower segment, this is the upper segment. Upper segment, you have a lot of muscle fibers, okay, lots of muscle there. Whereas lower segment, you have a lot of elastic fibers. So when the placenta is attached to the upper segment, let me draw it there. When the placenta is attached to the upper segment, okay, after the delivery, when the placenta is separate, this upper segment, because it has a lot of muscle fibers, they can contract more forcefully so that the bleeding can be stopped. Whereas when the placenta is attached to the lower segment, like in this way, okay, because it has a lot of elastic tissue, less muscle fibers, after delivery, this cannot contract forcefully, the patient will have more bleeding. Other reason is, so this is after delivery, what happens, the patient with placenta previa, they can bleed after the delivery. That's called postpartum hemorrhage. So this is a reason for postpartum hemorrhage as well. So why it is called antepartum hemorrhage? Because, okay, so I'm sorry. Yeah, this is the placenta, okay, and this is the baby's head, okay, this is the vagina, okay. The placenta is covering the birth canal like this way, okay. So patients with the placenta previa, antenatal period before delivery, right, placenta is covering the birth canal, baby's head is there. So does the husband knows about placenta previa? No, he's very poor. He doesn't know anything about placenta previa. So if something happens, okay, if something happens, this end, baby's head is there, placenta is between. So the placenta will get crushed in between the baby's head and something else coming from lower down. Okay, so because of this crushing, it can cause bleeding. So placenta previa can cause bleeding during the pregnancy period, or can cause predisposed to postpartum hemorrhage as well because of this reason. Okay, so typically, now don't tell this in the exam. Okay, typically patients with placenta previa, they come in at the middle of the night. So you know the reason why they're coming at the middle of the night. Okay, so because this is commonly after the coitus because of this location. Okay, so this is why it is called is a cause for antepartum hemorrhage, because during the pregnancy period, after 28 weeks, normally they can have episodes of bleeding. Okay. Now, in case of sorry, so I'm sorry. So placenta previa is a major reason for antepartum hemorrhage. This bleeding can be mild bleeding, small bleeding that doesn't cause any problem. But in some cases, this bleeding can be very massive, which can lead to the total blood volume loss within few minutes time. It can be very massive. So in placenta previa, bleeding is mainly happening from the placenta. That means bleeding is mainly coming from the mom, not from the baby. Because of that, in placenta previa, even the patient is coming with bleeding, baby is usually is not distressed. Okay, because the bleeding is mainly coming from the mom and the placenta, not from the baby. But if the mom's blood pressure drops, then that can affect the baby. Otherwise, in placenta previa, normally it causes bleeding from the mom, so the baby will be not affected initially. Placenta previa causes painless bleeding, no pain, only bleeding. So placenta previa does not cause abdominal pain, remember. And when you touch the abdomen is very soft and like a velagiri. Okay, it's not tender abdomen. Okay, it's a soft abdomen, painless bleeding. Bleeding is coming from the mom, so the baby is intact. Okay, right? This is typical of placenta previa. Okay, now compared to that, the second reason, so if I go back to the presentation, yeah. So in this picture, it's very clear. Placenta is covering the birth canal. So this is the baby's head. Okay. So it can cause bleeding. This is the baby's head. So this is the vagina. So if there is a trauma, like sexual intercourse, it can crush the placenta, which can cause bleeding. Okay. This is the lower segment. This is the lower segment, and this is the upper segment. Okay. Right. Okay. So depending on the position of the placenta, there can be 4 gradings. This is the, sorry. Yeah. So this is called the first degree. First degree means, now this is the arbitrary line, upper segment and lower segment. Okay. In this case, placenta is coming closer to the internal os, however, not reaching the internal os. This is called the grade 1 placenta previa. Grade 2 means placental edge is reaching the internal os, however, it is not covering the os. Birth canal is still intact. When it comes to the third degree, when it comes to the fourth degree, see fourth degree placenta previa, placenta is completely in the lower segment, and it is symmetrically covering the internal os. It is situated symmetrically on the internal os. Grade 3 means in between grade 2 and grade 4. Grade 3 means placenta is again completely covering the internal os. However, it is not symmetrical. One major part is onto a side. So there are 4 gradings. Grade 1, grade 2. Grade 1 means coming to the lower segment away from the internal os. Grade 2 means coming to the internal os but not covering. Grade 4 means completely covering and it is symmetrical on the os. Grade 3 means again completely covering, however, not symmetrical. Okay, right. Right. So when you come to the next thing, that is called, that next reason for antepartum hemorrhage is placental abruption. Placental abruption means placenta is separated from the uterine wall before the delivery of the baby, because after delivery normally the placenta should separate. After delivery, placenta should separate from the uterine wall and should come out. But when this thing happened before delivery, what will happen? Baby get the oxygen through the placenta. If the placenta separate, the baby will not get any oxygen supply. So this is called placental abruption. This is the second reason for antepartum hemorrhage. So go back to the next picture, right? There are two types of placental abruption. If the placenta is high like this and the central part, let me get the spotlight again, okay? Like in this case, placenta separate, normally not completely separated, halfway it is separated. However, the bleeding happens here, the blood is not coming out because it is sealed off there. This is called concealed abruption, because the bleeding is inside, you can't see. Whereas in this case, placenta separate and the blood is leaking out through the vagina. This is called revealed abruption. So basically there are two types of abruptions, okay? One is called concealed abruption, other one is called the revealed abruption. This is concealed, this is revealed. Revealed means blood is just coming out. So compare and contrast to placenta previa. What is the difference between placental abruption? Clinically, placenta previa does not cause pain. So it is painless bleeding. Placental abruption is typically causing abdominal pain. Sudden onset severe abdominal pain in pregnancy is placental abruption until proven otherwise. Sudden onset severe abdominal pain in a woman is ectopic. But in a non-pregnancy, sudden onset severe abdominal pain in pregnancy is until proven otherwise is abruption. Okay, so you have abruption. Okay, so abruption always painful. Placenta previa is not painful. When you touch the abdomen, placenta previa, abdomen is very soft and non-tender, whereas abruption causes tender, severely tender abdomen. It's called woody, hard, tender abdomen. It's like wood, right? Woody, hard, tender abdomen. Okay. Other difference is placenta previa, bleeding occurs from the mom or from the placenta. Okay. So because of that, baby is not affected initially. But when it comes to the placental abruption, bleeding is coming from the baby as well. So directly this will affect the baby and the baby will show signs of fetal distress. If you are not delivering this baby, baby is going to definitely set the pochi because there is no blood supply at all to the baby. Okay, so one difference is placenta previa, painless, abruption painful. Placenta previa, abdomen soft, placental abruption, abdomen woody, tender. Placenta previa, baby is normally intact initially, but abruption, baby will show signs of Sohon Lakunu from the beginning. Okay, and when you put a CTG, placenta previa, baby looks fine. CTG means the assessment of the baby's heart. Baby looks fine, but in abruption, baby will show features of fetal distress, decelerations and all. Okay. Other thing is patients with placental abruption, okay, they can have patients with placental abruption, they can go into acute what is called DIC. OIC, what is DIC? DIC means disseminated intravascular coagulation. So within the blood vessels, all the clotting factors are utilized to develop blood clots. That is called DIC, disseminated intravascular coagulation. Okay, so that happens quickly in abruption, but placenta previa, DIC, is not a common manifestation. So those are the differences between placenta previa and placental abruption. Okay, clear? Is that clear? Right. So in in the clinical scenario, if a patient comes with the antepartum hemorrhage, you should be able to differentiate placenta previa and placental abruption. And one more factor is placental abruption is a clinical diagnosis. You don't need ultrasound scan to diagnose this condition, abruption. Sorry. Whereas placenta previa, to diagnose placenta previa, you need to have a ultrasound examination. So those are the differences between placenta previa and placental abruption. I will explain the vasa previa also, and after that we will discuss a clinical scenario. The third, the reason for antepartum hemorrhage is called vasa previa. What is vasa? Vasa means vessels. What is previa? Again, priyaganang in a way, low. Vessels are low. In these conditions, vessels are low. You can say this is the main placenta. Okay, see this picture. This is the main placenta. Sometimes there are some accessory placental parts on the other side also. Single placenta, however, there are accessory lobes. And these lobes are interconnected by fetal blood vessels. These blood vessels belonging to the baby, directly connected with the baby. Okay, so these blood vessels are very close to the internal os. So typically what happens is at the time of labor, usually at the time of labor, or at the time when you rupture the membranes, these blood vessels can easily break. So which causes bleeding. And this bleeding is mainly coming from the baby. So this is purely not a maternal, it's a fetal emergency. Unless you deliver these babies, baby is going to definitely die. So they need a very urgent cesarean section and deliver. Fortunately, vasa previa is not common like placental abruption or placenta previa. So better to know about this condition, but not common. So antepartum hemorrhage, three causes: placenta previa, abruption, vasa previa. And this one also causes typically painless bleeding. Here, bleeding is mainly from the baby. Placenta previa bleeding is mainly from the mom. Okay, right. So now you will be given a scenario like this. Okay, right. So you are the house officer again in the antenatal ward. Okay, patient is coming at say 33 weeks with bleeding. How are you going to manage this patient? Okay, scenario is okay. Scenario is patient is coming at 34 weeks with episode of bleeding. Okay, how are you going to manage this patient? So how are you going to start your conversation? You have to tell that, sir or madam, whoever the person who is in front of you, I will consider this is as an emergency. I will attend urgently. That is your first sentence should come out. Okay. Suppose when they ask about antepartum hemorrhage, if you don't know anything, don't just blank. What is antepartum hemorrhage? When the examiner asks what is antepartum hemorrhage, you have to tell something. Okay. So best thing is always you can take some time by telling that, sir, this is an antepartum hemorrhage. I would consider this an emergency, obstetric emergency. Okay. Then how will you proceed? Again, any emergency approach is airway, breathing, and circulation. But remember, most of the cases, these patients are not unconscious. Okay. So you have a chat with the patient. If the patient is conscious, that means airway is okay. Then the next thing is breathing. If the patient is having heavy bleeding, massive bleeding, give oxygen via face mask. Next thing is the circulation. Okay. To assess the circulation, what you have to do is ask the nurses to put two white ball cannulas, send blood for cross matching. Okay. Then till the blood is available, you can start fluids. Now the patient initially, the pulse rate was 130, blood pressure was low. Now with the fluid, now the things coming up. Okay. Then next thing is, then you have to find out what is the reason for this bleeding, whether this is abruption or whether this is previa. How you differentiate that thing? It's very easy. Take a brief history. Ask from the patient whether you have abdominal pain. Amma bade කැක්කුම තියනවද? Amma වයිරු වලිකිද? යක වලිරු වලිකිදා තියෙනවා නම් that means pain and bleeding means what? It's abruption. Okay. Just bleeding means it's not abruption, highly unlikely. So get a brief history. Then examine the tummy. If the abdomen is soft, what is that? Most likely previa. If the abdomen is tender, it's most likely abruption. Other thing is, do a CTG. If the CTG is baby is happy, unlikely an abruption. If the CTG is abnormal, it's likely abruption. So likewise, you have to differentiate. If there is abruption, what is your management? If there is abruption, your management is emergency delivery. Most likely, most of the patients need emergency cesarean section for the delivery. Okay. If if your diagnosis is placenta previa, okay, if the bleeding stops, most of the cases, patients with placenta previa, initial bleeding episodes are not that heavy. So they have bleeding and after that bleeding stopped. Okay. So in placenta previa, if the bleeding stopped, okay, what you can do is you can just observe the patient till the baby achieved maturity. What do you mean by maturity? At least baby come to 34 weeks, provided that there is no ongoing bleeding and the mom is stable in placenta previa. In that case, you can give dexamethasone to accelerate the lung maturity. Give steroid, mature the lungs, and later consider delivery after 34 weeks. However, if the patient is unstable, heavy bleeding, ongoing bleeding, whatever the gestation, you have to go ahead and deliver the baby. Most of the cases, you need cesarean section for the delivery. So with regarding antepartum hemorrhage, there are three causes: placenta previa, abruption, vasa previa. Vasa previa is not common. Placenta previa and abruption are the two common things. So you should be able to define what is placenta previa, what is placental abruption. Then you should be able to differentiate clinically. How are you going to differentiate placenta previa from abruption? Okay, those clinical parameters you have to use. Okay, then if it is abruption, you have to go ahead and deliver the baby soon as possible. If there is placenta previa, patient is stable, no ongoing bleeding, you can deliver the baby later after giving steroids. If the patient is unstable or ongoing bleeding, go ahead and deliver the baby soon as possible. Don't think about steroid in that case. Okay, clear, right? So we have discussed the early pregnancy bleeding and antepartum hemorrhage. Antepartum hemorrhage, you should know the definition, and as well as antepartum hemorrhage, you should know the definition and the causes, three causes, and what are the differences between them, and how are you going to manage them. Okay, the main part is the postpartum hemorrhage. Okay, sorry. The other part is postpartum hemorrhage. So we will go back to our presentation. If you all have any questions, you can ask. Okay, if there are questions, you can ask regarding what we have done so far. All right. තේරෙන්නේ ටිකක් උනක් කමන්නේ මේ වචනේ තියෙනවා නම් කියවනවා නේද? Then right. So we have discussed all these things: placenta previa, placental abruption, maternal collapse, okay, cardiac collapse, and all these things we have discussed. So the last part today I'm going to discuss with you guys is what is called the postpartum hemorrhage. Okay, so postpartum hemorrhage. Now you know why I have put this picture, because the story behind in this case why that lady died because of postpartum hemorrhage. Okay, so whenever you discuss postpartum hemorrhage, this Taj Mahal also come to the mind, right? So postpartum hemorrhage, as I told you initially, also a very important part in your emergency, right? It can appear at any stage. Okay. What is the definition of postpartum hemorrhage? The definition of postpartum hemorrhage is, right, bleeding after the delivery more than 500 ml. By definition, bleeding more than 500 ml after the delivery is called postpartum hemorrhage. Okay, postpartum hemorrhage. Okay, so how do you measure this 500 ml? After delivery, will you keep up some ball or something underneath and measure all the blood loss? Now you are checking, now it's 250, not a postpartum hemorrhage. 300, no, not a postpartum hemorrhage. 450, still not a postpartum hemorrhage. Now it is 500, now postpartum hemorrhage. No, it's a theoretical the definition, this 500 ml. So postpartum hemorrhage, the practical definition is actually, if you think bleeding is more than the normal after the delivery, that is enough to say this is postpartum hemorrhage. You don't normally wait till 500 ml blood loss. In case of a cesarean section, it goes up to 1 liter. It goes up to 1 liter. But in normal deliveries, it's 500 ml is the margin. So when it comes to the postpartum hemorrhage, there are two types. Like anything else in the obs and gynae, everything is divided into two. Okay, in postpartum hemorrhage, there are two types of postpartum hemorrhages. Okay, PPH divided into primary postpartum hemorrhage and secondary postpartum hemorrhage. Okay, why we have divided these things into two things? Okay, because the management is different. In the exam, most likely you will get the question from primary postpartum hemorrhage. What is primary postpartum hemorrhage means? Bleeding occurs after delivery within first 24 hours. Within the first 24 hours, patient will have bleeding. Secondary postpartum hemorrhage means that bleeding occurs after 24 hours up to 6 weeks postpartum. After 24 hours up to 6 weeks postpartum. Okay, the courses are different, management is different. So mainly you will get the question from this part, there is a primary postpartum hemorrhage. Okay, right. So now you can see those days how this postpartum hemorrhage occurs and why the moms died. Patient delivered and no one to attend home deliveries. Patient is bleeding and bleeding and bleeding, and ultimately they ended up in maternal death. This is a real scenario where a massive postpartum hemorrhage happened. You can see the blood everywhere. It's pouring on the floor, wetting the floor. So this means it's a massive obstetric hemorrhage. Like the bleeding should be around 3 liters. It's a massive kind of bleeding. Okay, so the postpartum hemorrhage is one of the most severe kind of acute bleeding. Okay, right. So when it comes to the causes for when it comes to the causes, yeah. Sorry. When it comes to the why the primary postpartum hemorrhage occurs, there are various reasons. Sorry. Yeah. So when it comes to the primary postpartum hemorrhage, okay, the causes wise, 90% of causes, reason, 90% of cases, the reason is what is called atony. Whereas another 10% is due to what is called trauma. Not soma, it's trauma. Okay. Soma merla then godakkal. Okay. So primary postpartum hemorrhage, 90% of cases, the reason is atony. And the 10% of cases is the reason is trauma to the genital tract. So this is the uterus. Okay, right. So after the delivery, now the placenta, now it's like this, the blood vessels, okay, placenta is attached somewhere there, and the blood vessels are going in between the muscle fibers of the uterus. Okay, so after the delivery, the uterus should contract forcefully. The blood vessels are going in between the muscle fibers. Okay, these muscle fibers need to contract forcefully to constrict these blood vessels. That is called good uterine tone. However, after delivery, if the uterus is not contracting, these blood vessels are still opened, and they can cause massive bleeding. Okay, so when the uterus is not contracted after the delivery, it can cause massive postpartum hemorrhage. Okay, massive postpartum. This is the commonest reason for primary postpartum hemorrhage. So, what are the causes for this? What are the causes why this? Uh, uh, Sorry. What is the reason why the uterus is not contracting after the delivery? There can be, say, various causes. Yes. Now, suppose patient is coming with the first pregnancy for the delivery. Okay, so the first pregnancy, during the labor, the womb contracts, relax, contracts, relax, contracts, relax, and the baby delivered, patient is going home. Second time also she is coming with the pregnancy and for the delivery. Okay, the wound contract, relax, contract, relax, contract, relax, baby delivered, uterus contract, no PPH, baby, mom is going home. Suppose this dad or the father is a very strong person, very active person. So because of that reason, this lady is coming for the third time also with the pregnancy. Okay, and she's going into delivery, and the womb again contract, relax, contract, and the bleeding stop. Suppose she is coming for the fifth or the sixth time, like a fashion, okay, for the delivery. So what happens? The uterus is not, the contractions are not strong now because the uterus is exhausted. It contracts, relax, contracts, relax, contracts, relax. After the delivery, what happens? Uterus will not contract. But on a bamboo uterus. Then what happens? After delivery, uterus is not contracting, the patient will go into atony and massive PP. That's why it's called the multiparity increase the risk of postpartum hemorrhage. The same scenario when it happened in a prolonged labor, when the labor is going hours and hours, ages and ages, right? So in that case also, uterus contracts and relax, and at the end, uterus is exhausted. So no more contractions after the delivery. Other reason is when there's an infection inside, then again is another reason. Other reason is over distension of the uterus. When the uterus is over distended, okay, what happens? Like in multiple pregnancies, polyhydramnios, anything, when the uterus is over distended, right? So this is a normal pregnancy with the uterine distension. When you have multiple pregnancies, twins, triplets, and all, you can see these muscle fibers are, in this case, it is this much stretched, but in this case, the muscle fibers are this much stretched. So when it is overstretched, it will not go back to the original size after the delivery. So atony. So typical examples are multiple pregnancies and all these polyhydramnios and all these problems. What else? When you have a large fibroid sitting in the myometrium, this fibroid will obstruct the contraction after the delivery that can lead to atony. Okay, so infections, prolonged labor, multiparity, all these things can lead to atony. Okay, then what is the other reason for primary postpartum hemorrhage? That is the trauma. Okay, trauma to the genital tract. Where can you get the trauma? Trauma can be on the vagina, vaginal tears, or the episiotomies. Okay, tears here, tears there, or cervical tears, which causes bleeding, or sometimes uterine rupture. Any tear which can cause bleeding is another reason for postpartum hemorrhage. All other causes, and you can categorize as other causes for primary PPH. What are the other causes? Like bleeding disorders. Patients with bleeding disorders after delivery, they can have PPH. Patients with PIH or preeclampsia, actually, preeclampsia, they have bleeding problems, platelet problems, HELP syndrome. They all can cause bleeding after the delivery. But those are not common. Commonest thing is what is called uterine atony. The second thing is trauma, and other causes are not common, like bleeding disorders, pregnancy, preeclampsia, and all these things. Okay, right. So we will go back to our presentation. Sorry. Right. Sorry, right? So, oh, sorry. All right, here we go. Right. So this is the end results. So this is what is I called you the uterine atony causes the postpartum hemorrhage. Okay, you can see clearly in this picture, the blood vessels are going. Can you all see this? Sorry. Yeah, you can see nicely the blood vessels are going between the muscle fibers. So if they are not contracted after delivery, it can lead to atony and bleeding. Okay, so you can see in this picture where well contracted uterus and the non-contracted. Hello, any problem?
Can't see, sir. Can't see you. Can't see anything.
Wait. Can you all see me now?
Yes, sir. Yes, yes.
Okay, just 1 second. Can you see now?
Yes,
The
sir.
presentation. Okay, presentation you can see. Okay, excellent. All right. So in this picture, you can see this is a contracted uterus after the delivery. You can see the muscle, hardly any blood supply because all the blood vessels are constricted. Whereas when the uterus is not contracted, you can see the massive blood supply to the uterus, and these blood vessels are still open, which can cause massive postpartum hemorrhage. Yes. Now, when there is now, we will discuss a clinical scenario now, and then we can discuss what we are going to do. Okay. Now, suppose now again, you are the house officer, you are in your quarters, okay, after relaxing, okay, after a heavy duty, you are in the quarters, middle of the day, you are now sleeping, okay. Now the room also dark, completely dark, okay, you are in a deep sleep. So then after some time, you received a call from the labor room, one of the nurses calling you, doctor, other patient deliver kara podda bleed again, right? They will give a call like that, okay, podda bleed again. So a patient having bleeding after delivery, it is very serious. That is postpartum hemorrhage. Okay. So then, how are you going to approach this case? You are still in the quarters. Suppose the lights are dimmed and you can't see anything. What will you do first? Of course, you will open up your eyes, and then by this time the sarama may be there or may not be there. So you have to get your sarama back, okay? And you are now answering this call. You are still with the call on the call, okay? So what are the information you can gain from the nurse or the midwife? Because they are not, I mean, they are not giving accurate information. Accurate in the sense they are not taking those things into serious consideration. But you all know that bleeding after delivery is not a joke. So what is the next thing you are asking from the patient? How much bleeding she had? How many pads you have removed? Okay. Or else you can ask what is the pulse rate, what is the blood pressure, and get an idea. The nurse will say, okay, doctor, blood pressure is okay, but the heart rate is 140. It's doctor. Is it a aula or not aula? It's a very, very complicated story. So patient pulse rate is 140 means patient has bled a lot. So what will you do next? Then on a sarma and the then calcium and the gun less, okay. So You ask the nurses to do the A, B, C in the labor ward till you arrive the scene. Okay. So the first thing is the airway. So ask from the patient whether the patient is conscious or not. If the patient is conscious, okay, don't worry about the airway. Then ask them to give high flow oxygen. And ask the nurses to put two white book annually, same time take blood for cross matching and send to the lab. Now you have dressed with your the trouser and all. Now you are ready to come. And while you are coming to the scene, to the labor ward, you are in the contest. Meantime, what you can do? Meantime, inform all your seniors and everybody. Call for help. This is going to be a real emergency. So to whom you are going to inform? Inform your seniors. That is your registrar, SHO, whoever the person, and the consultant. Straight away, you can inform the consultant also. Inform him. Like that, you inform him and inform the theater team, inform the blood bank, right? And inform the anesthetists and everybody. While you're coming, you can inform them. And don't forget, inform your girlfriend also not to disturb. Okay. Now you came to the scene. When you came to the scene, right, you can have a visual assessment of the blood loss, how much blood. When you see this kind of a picture, you know it's a massive hemorrhage. Okay. So you can go through the airway, breathing and circulation. See, patient is conscious, okay, airway is okay, but make sure the patient is getting oxygen, make sure patient is having a 2 IV line, and then patient is having 2 IV lines and getting fluid and sending them fast. Okay, still the blood is not ready until there is no senior person close by. So what you can do? So quickly touch the abdomen and see. Okay, so you can examine the abdomen and see. If the uterus is, you can diagnose uterine atony very quickly and easily when you touch the abdomen. When the uterus is not contracted, it is soft and boggy. Upper level of the uterus is above the umbilicus. Okay, but if it is well contracted, you can see the very hard consistency of the uterus. So when you palpate the abdomen is soft and boggy, not contracted. So what is your diagnosis? It's atony. You know this is atony. Then what you are going to do? Immediately, you have to ask the nurses to start drugs to contract the uterus. Now you are dealing with a real atonic case. Okay. So what are the drugs you are going to start? These are the drugs you are going to start. First thing is the syntocinon. Syntocinon, or is also oxytocin is the generic name, but you can use the syntocinon word also because it's a common thing. Okay. So you can use syntocinon or the oxytocin, right? So the dose is, in this case, you give 5 units bolus followed by 40 units per, 5 units bolus followed by 10 units per hour infusion. I repeat it again. Okay. So you will give 5 unit bolus, or bolus means all of a sudden you give 5 units IV. These are IV. Okay. Give IV 5 units bolus and 10 units per hour infusion. You set up an infusion 10 units per hour. Okay. So in an hour, you are sending 10 units of syntocinon to the patient. And meantime, you don't have to wait. You can start the second drug also. Second drug is what is called ergometrine. Ergometrine doses, you can give 0.5 milligram IM or 0.25 micrograms IV. Half dose, 0.25 micrograms IV or 0.5 milligram IM. Give ergometrine. What are the contraindications to give ergometrine? Heart disease and preeclampsia. If those are there, you can't give ergometrine. Remember, never give ergometrine in case of heart disease or preeclampsia. But all other patients you can give. But syntocinon you can give. Okay. And the other thing is you can put the patient on misoprostol also. Okay. You can put her on misoprostol. Sorry. Yeah. You can put her on misoprostol as well. How do you put misoprostol? When you put misoprostol, you can use any route. You can use oral, sublingual, vaginal, the rectal, whatever the route you can use. Okay. But be careful, don't put misoprostol vaginally. Why vaginally? Patient is like this. Okay, right? Patient is having heavy bleeding coming from there. So what you're going to do is you're going to put misoprostol vaginally. What will happen? With the blood flow, all the misoprostol will be flushed and will be on your pasted on your face. So don't put misoprostol vaginally in case of a bleeding patient. Best thing is use rectal route, per rectal misoprostol. Okay, right? So, sorry. Uh, yeah. So put misoprostol per rectally. You can use 4 to 5 tablets. That means 800 micrograms to 1 gram. 4 to 5 tablets. Okay. The other thing is you can give tranexamic acid also to achieve a good blood clot, good hemostasis. You can give tranexamic acid, 1 gram. So now you are dealing with the atonic patient. What you have done? You have called for help till the call is coming, till the help is coming. You are assessing the patient, you are resuscitating the patient. You have started these drugs, indocyanine, ergometrin, tranexamic, misoprostol. Okay. Then meantime, what you can do is you can do the uterine massaging. You can massage the uterus abdominally, squeeze the uterus, keep it for some time and release it. Squeeze it, keep it for some time, release it. Like not like Thai massage, you have to do a proper squeezing of the uterus and achieve a good uterine tone. Okay, so squeeze it and release it, squeeze it and release it for some time. That's called uterine massaging. If that is not helpful, next step is you can see with this picture, right? You can do what is called bimanual compression. Okay, bimanual compression. Bimanual compression means you insert one hand, into the vagina, okay, and then other hand on the abdomen, and then you can give a good compression of the wound. Okay, the people may be worrying how you can insert a hand into the vagina. Don't worry, this is vagina after delivery is so spacious. You can even park a BMW inside without any problem. So it's so spacious. So insert one fisted hand into the vagina and with the other hand, squeeze the uterus. Okay. Now suppose you are giving fluids, you are massaging the uterus, you are giving bimanual compression, drugs are coming from the one hand. Okay, so you have to tell the examiner, so it's a real emergency. I will assess the patient, I will breathe in and circulation, and then I will make sure that the patient is getting oxygen, make sure that patient is getting fluid, and I myself do the uterine massaging and bimanual compression. Most of the cases, the bleeding can be stopped to some extent with this bimanual compression, but in some cases, bleeding is continuous. What will you do next? Next step is you can't manage alone. There should be somebody senior accompany you. So next step is you immediately take this patient to the theater for what is called condom catheter insertion. Okay, even you can do this condom catheter insertion in the ward and take the patient to the theater. Say suppose we are doing in the ward. Okay, so how do you do the condom catheter insertion? This is very easy procedure, okay, and a life-saving procedure. Easy life-saving procedure. So how you do is, sorry. Sorry about this thing, right? So you take a, I don't know whether you can see, guys, right? This is the condom. Sorry, this is the Foley catheter, normal catheter, and this is the condom. Okay, so you insert this the Foley catheter into the condom. Okay, and this gadget should be placed inside the womb. Can you see that? Can you see
Can't
my
see.
point?
Can't see, sir.
One second. Wait, just give me 1 second. Okay, I'll draw it here. Sorry, I'll draw it here. This is the womb. Sorry. Yeah. Yeah. Okay. Okay. This is the womb. Okay. Can you all see now? I think yes.
Yes, sir.
Yeah. So you take a Foley catheter. The two catheter, have you seen the Foley catheters? Normal catheters? Take a catheter. Okay. Right. End of the catheter, you take a what is called condoms. Have you seen condoms? Do you know about condoms? Right. There are structures called condoms. Okay. You take a condom. Okay. And you insert this tip into a condom like this and tie the edge. Okay. And this gadget should be inserted into the womb, into the uterine cavity. And this is the other end of the Foley catheter. Okay. You connect a saline drip into this the Foley catheter. And through the Foley catheter, you send fluid under pressure. So the fluid will be going along the catheter into the condom, and the condom will be distending like this, like this. Okay. And when the condom distend, it will give a pressure inside the uterine wall. This is called the tamponade effect. This is highly, highly effective and life-saving procedure. No, you can use the normal catheter. You don't need to use a three-way catheter. You can use the normal routine catheter that you have in the ward setup. Okay, use the same catheter, put it like this, and send saline under pressure, and it will stop bleeding. So, boys, you all need to have at least one condom in your pocket. So there's an excuse for you guys. If somebody asks your girlfriend, asks, why you're keeping these condoms in your pocket, you can say, this is life-saving. This is to manage, this to prevent postpartum hemorrhage. This is to manage postpartum hemorrhage. It's life-saving. This is very simple procedure anyone can do. So after putting the condom catheter, you keep it for 24 hours, and then gradually you can take it off. Okay. So this is the abdominally, this is the fundus. Okay. Now the condom catheter is inside. Okay. After that, what you do is you mark the level of the fundus. Okay. And time to time, you have to monitor this level with the marker. If the level is going up, means if the fundus is rising, and rising means, what does that mean? If the fundus is going up like this, means even with the condom catheter, there is bleeding inside. So this is not effective. Take it out. If the fundus is remaining at this level, then you know, if that is remaining at that level, then you know there is no more bleeding. Bleeding is almost stopped now. Okay, so you can keep this condom catheter for 24 hours and it's highly effective. It is, it can be used in case of postpartum hemorrhage. Okay, right? So the same thing you can do with what is called Buckley catheter. This is a Buckley catheter. It's more expensive than this normal condom catheter, but the advantage is if there's bleeding here through this channel, the bleeding can come out in this Buckley catheter. But condom catheter, bleeding cannot come out. So that's why we are marking and we are assessing the fundal level. Okay, this is how it works. It's a very simple procedure. Okay. Now, if the condom catheter also fails, Daru, there is no other option. Rush to the theater and you have to do emergency operation. First thing is called B-lynch application. You don't need to know how you are going to apply the B-lynch. This is a stitch, going around the womb, right, uterus, and contract the uterus. This is not a pumpkin. This is after application of this the B-lynch. You can see uterus is well contracted and it will stop bleeding. Okay, so the next option is laparotomy and B-lynch application. If that one also fails, what is your next option? If that one fails, your next option would be what is called, systematic devascularization. That is, you reduce the blood supply to the uterus. How are you going to reduce the blood supply? The uterus get the blood supply. Yeah, I'll come to this one again. Yeah, so I'm going to draw the uterus again. This is the uterus, okay, right? So uterus get the blood supply through the uterine arteries from either side. Uterine artery arm comes and gives branches like this, okay? So initially what we do is you go and ligate bilateral uterine arteries. When the uterine arteries are ligated, the blood supply to the uterus will be reduced significantly, and that will reduce bleeding. However, ovarian arteries also give blood supply to the uterus, so you can't stop the blood supply completely. However, to a great extent, you can control the bleeding by ligating the uterine arteries. After ligation, also, if there's continuous bleeding, next option is uterine arteries start from the internal iliac artery. Okay, so you go and ligate the internal iliac arteries on either side and see whether bleeding can be stopped. Most of the cases, bleeding can be, in almost all the cases, you can stop the bleeding by ligating internal iliac arteries. But remember, Rajo, internal iliac artery is very close to the external iliac artery. External iliac artery is the one which supplies the blood supply to the legs. So accidentally, if you ligate this one, following day, you will be the most famous person on the Facebook and in the Sirasa TV. Okay, dostara visin rogiyage akula kapanaladi, right? So you have to make sure you are not ligating the external iliac, you are ligating only the internal iliac artery. Suppose you ligate the internal iliac also, Dargo, there is again still bleeding. So what is the next level? Internal iliac artery start from the aorta. What will you do? You go and ligate the aorta. Can you do that? No. After the ligation of internal iliac artery, no more ligations. That's all. Next option is you remove the womb. That is called the hysterectomy. Okay. If internal iliac artery ligation doesn't work, next step is you have to go and remove the womb. That is called hysterectomy. That is the last option. Once you do the hysterectomy, bleeding should stop. Okay. So this is the management of uterine PPH due to uterine atony. Sorry. Stop sharing. Yeah. Okay. So we have discussed in detail the uterine atony management. What will you do? PPH, primary PPH. What will you do? Initial thing is resuscitation. Whatever the cause, initial thing is resuscitation. Airway, breathing, circulation. Don't worry about the airway if the patient is alert, if the patient is alive. Okay, don't worry about the airway. Then the next thing is breathe in pure oxygen and assess the circulation. Send blood for cross-matching. Start fluids. Okay, then have a look at the abdomen. If the uterus is not contracted, that means atony. What you have to do? In case of atony, what you have to do is you have to ask the nurses, because you are the boss. Okay, you have to arrange your team. So you have to tell, I will arrange my team. How are you going to arrange your team? Because till a experienced person come, you are the boss as a house officer. So how are you going to arrange your team? You have to tell, well, like that, you arrange your team. No, not in that way. You have to tell that, okay, so you order things. Okay, can you like done? We are fluid patangana, we are blood bank like that. You are not leaving the patient, you are with the patient, but you ask the other people to do things for you. You are commanding. Okay, give commands. So if you detect a uterine atony, what you have to do? Ask the nurses to start drugs. What are the drugs? Syntocinon 5 units bolus followed by 10 units per hour infusion. Then the ergometrin, if there is no contraindication, 0.5 milligrams or 0.25 micrograms. Okay. Then misoprostol 4 to 5 tablets PR per rectal, and tranexamic acid 1 gram. You everything together. You don't have to wait one by one. You give everything as a bundle package. Give. And you try and massage it to very squeeze and keep it for some time, release it. Squeeze, keep it for some time, release it. And then bimanual compression, very important, do bimanual compression. Okay. Then If it is not settling, go for a condom catheter insertion. How long you can keep it? For 24 hours, you can keep it if you want. Okay. And if that is not working, take the patient immediately to the theater and go ahead and operate. Do a laparotomy and do B-lynch. If the B-lynch is not working, do bilateral uterine artery ligation. If the uterine artery ligation doesn't work, do bilateral internal iliac ligation. If that is not working, go for hysterectomy. That is the last option. However, a patient, this is now say, if a primary mother, first pregnancy, suppose ERPM student, after completion of ERPM, coming with pregnancy, first baby, PPH. So in that case, you don't do hysterectomy as the first line. That is the last option for you. But on the other hand, Jnanavati, coming from Kahatagastgiri or somewhere, or Tittapajjala or somewhere, okay, with the sixth baby, unwanted pregnancy, unplanned pregnancy, sixth baby, PPH atony. What will you do? Again, you do the resuscitation, you give drugs, bimanual compression, the condom catheter. If that is not working, you take the patient to the theater. Rather than doing B-lynch and these ligations and all, you can straight away go for a hysterectomy. So multiparous woman, the threshold for hysterectomy is low, whereas primary mother, you want to preserve the uterus. In that case, you have to delay your treatment. In the sense, the hysterectomy should be the last option. So in PPH management, there's a thing called golden hour. That means once you diagnose, within first hour, you have to come to a decision. What are you going to do for this patient? Whether you're going for a hysterectomy or whether you're going to do other conservative things. That is called golden hour. Okay. So regarding PPH, definition you should know. There are two types, primary, secondary. Main thing is the primary PPH. Okay. So how are you going to do? What are things you have to do? Resuscitation, very important. Drugs, uterine massaging, bimanual compression, condom catheter insertion, failing all, laparotomy, B-lynch, internal bilateral uterine artery, bilateral internal iliac ligation, hysterectomy. Okay, those are the things in PPH and uterine atony you do. I'm not going to take much time. About in 5 minutes time, I will discuss the secondary PPH. I know that you all are much exhausted now. Okay. Secondary PPH means Daru, bleeding occurs not within the first 24 hours. Patient going home after 24 hours, but coming back with bleeding. That bleeding is not massive like primary PPH. Reason is until proven otherwise, infection within the endometrial cavity. That is called the endometritis infection. So the management is again, airway breathing and that normal resuscitation process. They don't normally need any oxygen and all, but you have to give broad spectrum antibiotics like septic miscarriage. Main management is broad spectrum antibiotics. They normally respond to antibiotics. Okay, right? That is not normally questioned in your the VIVA emergency VIVA, but better know in secondary PPH. The common thing is primary PPH. Okay, so the things today, I think it's I mean, if I'm continuing, I'm okay to continue, but it's a bit tired for you guys. Okay, because of that, I'm going to stop today. Okay, so today what we have discussed is obstetric emergencies. Okay, under obstetric emergencies, we have discussed maternal collapse. I'll give you the note. I thought it's there, so I'm sorry about it. I'll give you the note of maternal collapse. Okay, and then we discuss obstetric hemorrhages. Obstetric hemorrhages, we discuss early pregnancy miscarriages, ectopic, antepartum hemorrhage, placenta previa and abruption, and postpartum hemorrhage. Okay, so please go through the note and get ready for them. You don't have to wait till the exam comes to start studying now. Okay, and I will do the second part. The second part will be more interesting, like shoulder dystocia, cord prolapse, amniotic fluid embolism, eclampsia, and all these things, and breech delivery. All these things I'm going to discuss with you all with the next session. Okay, that is also going to be a free session. I'll let you know that the time and the thing. Okay, so few things to remind again. Okay, so after these free sessions, I'm going to start the Viva course, that is 9 classes. Okay, after the 9 classes, your syllabus will be finished. And one more thing. Now, if you think like you want to have a experience how the emergency Viva is going to conduct, I'm happy to arrange some free sessions for you all through the Zoom. So I will be the examiner and you will be the student. Okay, then I can conduct like as in a real Viva how you have to face the exam. Okay, that is totally up to you. Okay, if you want individually, it's okay. Individually we can do, or else if you want to have a few people like that meeting, so we can do in that way. Let me know personally, then we can arrange some for you. That will be very important, because then you have the real experience how to answer in the Vivas, and what is the way to answer, how to tackle the things and all. Okay, so that is again totally free. Okay, so let me know, then it doesn't take much time, about say 10 minutes, 5 to 10 minutes time. We can have it, we can conduct a proper Viva session, and then that will be a good experience for you all. Okay, so the clinical, as I mentioned you all before, I'll try to arrange. Still, I'm having quarantine, so once I finish, I will get a hospital. So I'm trying to arrange the hospital visits for you all. And however, I'm going to do the demonstration, how to do the examination and all, and the instrument and everything. So will not be a problem for you when you go to the exam. Okay, so thank you very much for coming today and getting in touch. Okay, so as I promised you all, I will complete the syllabus and I will do all the necessary things. I will not demonstrate you all the unnecessary things. Okay, like doing major surgeries and all, these are useless things. They will not ask about these things, but I will prepare you for the exam point of view. Okay, and some people are thank you all for your reply, right? I hope your feedback, okay, what are things that I need to improve and all. Please leave a feedback at the end, not in a hurry. And the other thing is, I don't have any problem with anybody. Okay, so I'm not competing with anyone. Okay, I'm just conducting my classes, that's all. So if because of my class today, if someone class or other thing is crash, I'm really sorry about that. I'll make sure that that's not going to happen in future. Okay, so thank you all for coming today. And those who are interested about the future classes, you can join with the registration process and all. Okay, and if somebody is having a real financial difficulty or anything, so I can help you all. And the next when we start the classes proper, the picture quality and the setup and everything will be much better than this, because today I'm doing with my mobile. I'm really sorry about that. Okay, so all the best, and we'll meet up again. Thank you very much.
Thank you very much, sir. Bye.
Okay, bye-bye.
Thank you very
And
much,
those
sir.
who,
Thanks.
thank you. And one more thing, those
Thank you,
who
sir.
couldn't attend, I'm going to arrange another session for those guys. Okay, so please convey this message among your friends. Either I'm going to give the recording, rather than recording, I might do another live session for them. Okay, right. So share this message and keep in touch. Thank you very much.
Thank you, sir.
So much, sir.
Thank you. Thank you.